Welcome back. I think people can hear. All right, if you're able to hear, I can start the session. Yes, you can hear, you can see me. Okay, thank you, Daisy. Thank you. Yeah. Cool. So I want to show some images. I think everyone can see the image and you can tell what's happening over here. I want to show one device there. So that's a very common one. We have discussed already. What is that device that's shown in this particular kind of an X-ray? Yes, that is basically an aneurysmal clip that you're looking at here. So I think it must be visible. You can like a small kind of a screw over there. So this is basically an aneurysmal clip. So this is a very common image that you might get. And this is an example of an aneurysmal coil. So you can see that kind of a weird area that you're looking at. That's a aneurysm that is being coiled, and that's called a coil embolization. And this is an example of a basilar top aneurysm where it is before the coiling. The aneurysm, you can see the contrast is filling very nicely, but you can see the same aneurysm after the coiling. The contrast is not filling at all in that area. That is a successful coiling. That's what it means there. And this is an example of MRV showing cortical venous thrombosis for that matters. You can see on the right side, you're not able to see any filling at all. So this is what we define as something called filling defects. And this is very classical of a cortical venous thrombosis in a MR venogram. I think that must be it. So I think we can move on to the other types of strokes. For example, we have a dissecting type of a stroke, and we have cadasal, that is cerebral autosomal dominant arteriopathy with subcortical influx and leukoencephalopathy. That's what we call as cadasal. Anyways, fine. So, but let us start with the dissection first. We have discussed a lot about aortic dissection already. We know how aortic dissection is going to cause a stroke. Remember, aortic dissection causing a stroke is a contraindication for two things. One is you cannot do any thrombolysis in this setting. At the same time, you cannot use any anticoagulants as well, because the pathophysiology there is different. It's bleeding into the vessel. That's why you can't give thrombolysis and you cannot give any anticoagulation. So you have to make sure that it is contraindicated. None of this is used. But on the other hand, your carotid and vertebral artery dissections are completely different. So in the sense, like where here the treatment itself will be anticoagulation only. Because here the problem here is the thrombosis. Because of the dissection, there will be thrombosis that is happening, and the pathophysiology of dissection is completely different here, which we'll be discussing subsequently. And the treatment of choice itself is anticoagulation in this particular perspective. All right. Now, what is dissecting stroke and what do you mean by dissection? So that's the next thing we need to discuss. So I can discuss separately. So how a dissecting stroke really presents and how they come to the hospital. So we are talking about carotid and vertebral artery dissection. We are not going to talk about aortic dissection. So be clear in that. Carotid and vertebral artery dissection. Okay. How they're going to present, first of all, in the emergency department. So first thing is the most important thing that you need is the history of trauma. So most of the cases of carotid and vertebral artery dissection will be having a trauma history for sure. And most often the trauma will be happening in the neck region. Neck or in the lower part of the head region. So that is where you get the trauma. And it could be, for example, a flexion extension type of a trauma as well. It could be some sort of a flexion extension sort of a injury as well. So even that can result in development of this carotid and vertebral dissection. For example, a motorcycle race or probably even a car race, and the patient is participating. When a particular person, when they are suddenly decelerating and accelerating, that time they might get this flexion extension type of injury. Even that can result in the development of dissection over a period of time. And please understand the dissection usually start only in the extracranial vessels, and it's not going to start in the intracranial vessels. From the extracranial vessels, it can extend into the intracranial location, which means they can have intracranial extension. But basically, to start with, they are only going to have extracranial dissection. Later on, that might extend into the intracranial area. So what we are actually talking about is the extracranial carotid and vertebral artery dissection. So that's what happens in this setting. So what will be the features? Apart from the history of trauma that we are having in this setting, most importantly, there is another feature that is very common in both carotid and vertebral artery dissection, that is a Horner syndrome. Extremely common in the setting of a Horner syndrome. So whenever you have a history of neck trauma in a patient who's coming with Horner syndrome, it is almost certain in exam that you're dealing with a dissection. From this, you can now categorize into two, probably either a patient is having a vertebral artery dissection or the patient is having a carotid dissection. So how do you differentiate whether it's a vertebral artery or a carotid dissection? So as far as the vertebral artery dissection is concerned, the type of Horner that you're going to deal is a central Horner syndrome. Whereas in carotid dissection, carotid means we're talking about internal carotid artery dissection. So in ICA dissection, you're dealing with something called a peripheral Horner, which I'll tell you in some time. What do you mean by a central Horner and a peripheral Horner? And beyond that, vertebral artery dissection usually presents with the posterior circulation stroke-like feature. It will be similar to that of a posterior circulation stroke. Again, I'll come back to that in some time. Most of them, they'll be present like a lateral medullary syndrome-like feature. For example, they'll be having multiple cranial nerve deficits, especially the bulbar cranial nerves. Like for example, they might come with dysphagia, problems in voice production, dysphonia, problems in swallowing, that is dysphagia. They can come with this kind of picture. But hemiparesis is generally very rare. Hemiparesis is not a usual feature of a vertebral artery dissection because it's a posterior circulation stroke, which we'll be discussing subsequently. Whereas carotid dissection, usually they will present similar to that of an anterior circulation stroke-like feature, where hemiparesis is going to be extremely common in the setting of a carotid artery dissection. And at the same time, most of the patients with vertebral artery dissection will be having other features like syncope and that drop attacks is there. That's very characteristic feature of a posterior circulation stroke that will not be seen in carotid artery dissection. And more importantly, the subarachnoid hemorrhage, because of intracranial extension, the subarachnoid hemorrhage is common in the setting of a carotid dissection, whereas it's going to be rare in the setting of a vertebral artery dissection. We have a person who died of dissection whose name is Phil Hughes. We know that, 73 not out. He died in 2014, isn't it? With internal carotid artery dissection, which rapidly progressed to develop subarachnoid hemorrhage, and because of that, he was declared brain dead within a couple of days after the incident. And everyone should be knowing that, especially those who watching cricket, definitely will be aware of Phil Hughes and the tragedy that happened. Cool. So that is because of the dissection stroke only that he had. Nevertheless, now there are two new terminologies which you have. Yes, he didn't play in the 2015 World Cup. It's before that. It was in the local county test match. Yeah, Australia dedicated that to Phil Hughes. Cool. Riju is correct. But it happened much before that. He is a very good friend of Michael Clark. Yeah, in 2014 November in a county cricket. In the local Sheffield Shield Trophy. He got injured and he fell on his face forward and he didn't recover after that incident. And he declared brain dead within a couple of days and he died. Anyways. Fine. All right. He actually, we don't know exactly what kind of dissection he had, but we predict that it must be a internal carotid artery dissection that happened to him because of the, neck injury. Shubham is telling you look cricket freak. Yeah, to be honest, yes. Yeah, Shane Abbott. Shane Abbott is the unlucky bowler, yes. He's the bouncer bowled by Shane Abbott only. All right, so let us go back to what are the new terminologies that we have introduced here. The first new terminology we have introduced here is Horner syndrome, number one. And the second new terminologies that we have introduced is the anterior circulation stroke and posterior circulation stroke. These are the new terminologies that we have introduced. So anyway, we are going to discuss in detail about anterior and posterior circulation stroke. But before that, it's important to know something about Horner syndrome. So what is basically Horner syndrome? Horner syndrome has certain important features. Everyone knows that. You have been studying this from the first year, isn't it? From the first year, when you start dissection in the upper limb, that time in the brachial plexus, you would have studied about Horner syndrome within 2 months of your medical curriculum. And from that time, everyone would have mugged it up. What are the features of Horner syndrome? It starts from ptosis, and then it goes to meiosis. Then we have anhydrosis. Then we have something called loss of ciliospinal reflex. I'm going to write as CSR. And you have something called an apparent ophthalmos. So this is the thing that every medical student tends to mug up. Yeah, nase rhyme of MBBS. Ptosis, meiosis, anhydrosis, loss of ciliospinal reflex, and apparent ophthalmos. So 5 features, classic of Horner's. And Horner's itself has multiple etiologies which can happen in multiple situations. For example, when you want to divide Horner's in the first place, you can divide into a central Horner versus a peripheral Horner. Horner's is not that easy whenever you're going to answer a exam, because they will be asking in and out about the central Horner versus peripheral Horner. That's why it's very difficult. So first of all, let us identify and understand this in a very simple way. When we call it as a central Horner, when we call it as peripheral Horner, whenever there is a damage to the preganglionic fibers, it's a central Horner. Whenever there is a damage to the postganglionic fibers, those are called as peripheral Horners. So we need to know what do you mean by a central Horner and what do you mean by a peripheral Horner. For that, let us start from the autonomic nervous system where it starts. So to start with, where the autonomic flow starts from? Which place? Which place autonomic flow starts from? In the brain. Don't tell brain. Of course, we know it's in the brain. So where it starts? Yes, hypothalamus. Hypothalamus is the place where it starts basically. So I can write hypothalamus here. Okay. From the hypothalamus, it descends down in the brainstem. So let me draw. This is going to be the brainstem. So it descends down in the brainstem. All right. So in the brainstem, it's going to descend down as something called a lateral reticular formation. So typically the sympathetics are going to descend on, because parasympathetics has a different route. We're not going to talk about that. So these sympathetics are going to descend in the brainstem in the form of a lateral reticular formation. And once they reach the spinal cord, and they're down, once they reach the spinal cord, so let me write the spinal cord as a tubular structure here. Once they descend down in the spinal cord, there is a particular zone. We know what is that particular area. This is called the T1 to L2. That's the thoracolumbar outflow region. So from the thoracolumbar outflow region, they are going to synapse in different nucleus. These sets of nucleus that we are talking about, these are the first order neurons. These first order neurons end up in this nucleus. So these nuclei are basically called as intermediolateral nucleus. So let me put in blue. So these are intermediolateral nucleus. So that's where these first order neurons are going to synapse. And of course, you are going to result in development of the second order neurons. I'm drawing only few second order neurons, and these second order neurons are going to synapse in a bigger structure. So this is the sympathetic chain that is basically present throughout the spinal cord. So these are the sympathetic ganglia chain, or just call it as a sympathetic chain over here. So, and these second order neurons are what we refer to as preganglionic neurons. So from the intermediate lateral nucleus, you get the preganglionic neurons. And these neurons are going to synapse with the sympathetic chain. And the topmost one is the biggest, that's called the superior cervical ganglion. But apart from that, you are going to have like sympathetic chain throughout the vertebral column. It's not only present in the T1 to L2, even though the entire sympathetic flow is going to come out through the T1 to L2 only. That's why it's called a thoracolumbar outflow. But once it reaches the ganglion, it's like a freeway. It can go either way. It can go up, it can go down, it can go in any direction. It can go up, it can go down, or it can go in any direction. For example, these fibers that are coming from T3 can go up. These fibers that are coming from T1 can go down. So like this, they can have a variety of like movements up and down within the sympathetic ganglion. So that is why we tell autonomic nervous system is actually a generalized response. It's not a very localized response like T1 means they will have only response over T1. For example, if you see something dangerous, your heartbeat increases, you also sweat in all the areas. So it's a very generalized response because there is no localized response, but the entire outflow is actually coming from T1 to L2. But to be honest, once it reaches the that sympathetic ganglion chain, it's like a freeway. It can go anywhere, elsewhere, up and down, everywhere. So from the superior cervical ganglion, you're going to result in the origination of the third order neurons. I told you these preganglionic neurons are the second order neurons. From the sympathetic ganglion chain, you're going to result in the development of, origin of the third order neurons. And as far as the Horner's syndrome is concerned, the fate of the third order neurons is very simple. They're going to go along with the internal carotid artery. That is very important. And along the internal carotid artery, they are going to wind as a plexus and they move along the internal carotid artery. And where they are going to supply the structures of the head and neck, especially the eyes. That's what we are concerned with. And in fact, the head and neck, they're going to supply through that and through something called short ciliary nerves. We know that. But before that, one important point is the fact there are some few fibers called sweating fibers. These sweating fibers basically are going to be separating from the third order neurons. They're going to originate from the third order neurons only, but even before they get wound up around the internal carotid artery, they are going to get separated, and these sweating fibers are going to supply the face and head and neck, basically. All these points are important because you need to differentiate between the central horner and the peripheral horner. So basically, your problem can be in the first order neurons. The problem in the first order neurons can be happening in the brainstem level, or it can happen at the spinal cord level. So best example of a Horner syndrome that is happening at the brainstem level is going to be the, probably I can talk about a lateral brainstem stroke. So why lateral brainstem strokes? Because as I've drawn in this image, you can understand that the lateral reticular formation is the one that carries the sympathetic fibers. And of course, they are present in the lateral side of the brainstem. So any stroke that affects the lateral area of the brainstem, like lateral brainstem stroke, the best example for that is Wallenberg syndrome. Lateral medullary syndrome can result in the development of a central Horner syndrome. And remember, the lateral portion of the medulla is supplied by vertebral artery. That is why vertebral artery dissection also can result in lateral brainstem stroke-like picture. That's why they develop central Horner. So I can write another example, that is vertebral artery dissection, because vertebral artery supplies the lateral part of the medulla, mimicking a picture of a Wallenberg syndrome. So two important causes I told you already. Then apart from that, many other causes are there. For example, some causes in the spinal cord also may result in the development of central Horner, that is first order neuron lesion. Like for example, a syringomyelia. Rare cause, but still possible. Syringomyelia can affect the first order neurons causing central Horner syndrome. Apart from that, basal meningitis is there. There are many demyelinating lesions can cause central Horner syndrome. Then you have a group of disorders called Chiari malformations, Arnold Chiari malformations. All these things can result in the development of central Horners. Of course, you have another cause for central Horners. For example, if you damage the second order neurons, these are basically preganglionic neurons. What are the things that can damage the preganglionic neurons? That is the second order neurons we are talking about. Anything that has a problem in the apex of the lung, or probably that affects the fibers that are going to the superior cervical ganglion. For example, you have a Pancoast tumor very commonly. This is what it was studied in the first year anatomy itself. Lung apical tumor can damage the second order neurons on the way when they are reaching the superior cervical ganglion. So that area, your second order neurons can be affected, or probably some other thoracic outlet syndromes like cervical ribs. Very rarely aortic dissection of aorta, or common carotid artery dissections can produce this kind of second order neuron involvement, but that's very rare, so I'm not going to tell that. And severe lymphadenopathies, especially if it happens in the superior part of the mediastinum, like Hodgkin lymphoma, non-Hodgkin lymphoma, leukemia. So, but of course, the most important of all this that you need to know for exams is the Pancoast tumor. Very commonly asked question in exam. and of course the cervical rib as well. And then you can have damage to the third order neurons. Third order neurons are extremely sensitive for damage at the level of the internal carotid artery. So that is why whenever you talk about the third order neurons damage, you think about the internal carotid artery dissection. That's the usual scenario. And of course, this internal carotid artery is going to enter something called the cavernous sinus. So you can get in cavernous sinus lesions also, because the internal carotid artery, of course, has something called a cavernous segment. So in cavernous sinus lesions like cavernous sinus thrombosis, you can get a peripheral horner. That is the horner that is due to third order neuron involvement. Then you can get Horner syndrome in trigeminal autonomic cephalgias. The best example for trigeminal autonomic cephalgia is a cluster headache, where once again the third order neurons are involved in this particular section, or probably any other cortico-cavernous fistula. So many entities are there. So, but most important in this particular group is internal carotid artery dissection. Most important in the first order neuron group is lateral brainstem stroke in the form of Wallenberg syndrome or vertebral artery dissection. So these are going to be extremely important from our exam standpoint. So now I need to differentiate between the central horner versus a peripheral horner. In order to differentiate a central versus a peripheral horner, first I need to know where the lesion is. The lesion of the first and second order neurons, we call it a central horner. In fact, in short, I can write anything that is preganglionic. If the damage is sustained in that area, we'll call it as central horner. The third order neurons, which means anything that is post-ganglionic, we're going to call as peripheral horner syndrome. And one important difference that you need to know with regards to the central versus the peripheral horner is the fact that in the peripheral horner, which commonly involves the third order neurons that are wound around the internal carotid artery, will not affect the sweating, which means anhidrosis is not a feature of a peripheral horner. That's really, really important. For example, anhidrosis is a very important feature of a central horner, which is not a feature of peripheral horner, because that's why I told you that sweating fibers diverge away from the internal carotid artery and they are not wound around the internal carotid artery. And there are some tests that can differentiate the central versus peripheral horner as well. For example, you have a ciliospinal reflex that's called a CSR. You can imagine like upper motor neuron lesion versus a lower motor neuron lesion. Central is like a upper motor neuron lesion, whereas peripheral lesions is like a lower motor neuron lesion. You can imagine like that. Reflexes are usually preserved in upper motor neuron lesion. So, the ciliospinal reflex will be present in the setting of central horner, whereas it will be absent in the setting of a peripheral horner. So, where you can imagine like a lower motor neuron type of lesion. Then we have something called a hydroxyamphetamine test. Amphetamine increases the noradrenaline concentration in the synaptic terminal. So when you give a hydroxyamphetamine test, usually you will get dilatation of the pupils with central horner, which means the patient will have meiosis, small pupils. If you give hydroxyamphetamine, there will be dilatation in the setting of a central horner, but there will be no effect in the setting of a peripheral horner. Similarly, there are many other tests like adrenaline test. Usually we use a solution called 1:1000 adrenaline. If you use 1:1000 adrenaline test, then in a central horner, you will generally see no effect. In central horners, you will see no effect, but in the peripheral horner, you will be seeing dilation along with the lid lag. And then you can use many, cocaine-based tests are also there, but it is not available right now. So we don't use the cocaine-based tests as of now. Yes, this is nothing but amphetamine test. There's a hydroxyamphetamine test. Central will show effect, but peripheral will not show any effect. Whereas adrenaline testing, the peripheral only will show effect and central is not going to show any effect. So this is how you basically differentiate central versus peripheral horner. But all these things are not at all important. Whether the patient is having horner or not is what the question is. And most importantly, clinically, we can easily differentiate the central versus peripheral horner based on whether the patient is having anhidrosis or whether the patient is not having anhidrosis. This is the most important as far as the exam is concerned. Other things may be just for like one-liner purposes, but apart from that, this is the most important feature that differentiates the central versus the peripheral horner. I think now you can be sure what are the things that causes central horner and what are the things that causes peripheral horners, and how will you really differentiate the central horner from peripheral horner in this perspective. So that's why horners is very, very important. For example, in the exam, whenever they give a word called painful horner, there are something called stereotypical questions in exam. So whenever they give a word called painful horner, that is equal to ICA dissection unless proved otherwise. That's all. When they give something like this, it is ICA dissection only. There is absolutely no doubt about that. And of course, the investigation that you're going to do is CT angiogram. That's the best investigation of the neck. That's what you have to do. Plus, along with that, you can do a CT or a MRI brain, because you need to find out the stroke as well. It's better to do an MRI brain along with CT angiography of the neck. That's going to tell you the diagnosis of, MRI brain can show infarct in the lateral medulla, but CT angiography or MRI angiography of the neck is the one that's going to show you what is the actual lesion that is causing this kind of a stroke. That is, angiography is what we have to do. And as far as the treatment is concerned, anticoagulants are the basic mainstay, because here the pathophysiology is completely different. As I told you here, the trauma will result in rupture of the vessel, causing basically thrombosis throughout the segment of the particular vessel. So here anticoagulation is going to be the mainstay. For example, I'm going to use a heparin and a warfarin. This is how you treat a dissecting stroke. And finally, you have the last but not the least, that is the CADASIL. We know the nomenclature of CADASIL, that is cerebral autosomal dominant arteriopathy with subcortical infarction, leukoencephalopathy. Yeah, anticoagulation for both the types of dissection, doesn't matter. So CADASIL is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. That's what we call it as CADASIL. So CADASIL has some peculiar ways of presentation. For example, it is an autosomal dominant disease, we know that. So the name suggests, so that's why it's going to have an extremely strong family history. It's very disease with high penetrance as well. So definitely will have a strong family history. Apart from that, it is going to be due to mutations of a gene called NOTCH3 gene, which is present in chromosome number 19. I don't know why this question was asked. Once upon a time, it was asked in JIPMER exam, I think in 2018 or 19. It's due to mutations of the NOTCH3 gene present in chromosome number 19. And usually the disease evolves over a period of time. For example, when the patient is in 20s, they used to get severe migraine-like headaches. When the patient reaches 30s and 40s, they tend to develop multiple and recurrent lacunar infarcts. In the 50s and 60s and 50s and above 50s, they used to develop dementia. So this is a characteristic evolution of a CADASIL. This is how they present. And if they give some history like this in exam, 20s severe migraine-like headaches, 30s and 40s multiple and recurrent lacunar infarcts, and in the 50s if they get dementia, of course you're going to deal with something called a CADASIL. So that is cerebral autosomal dominant arteriopathy with subcortical infarction and leukoencephalopathy. It's a genetic condition. I think with this our differentiation of stroke into multiple classification is complete, and now we have to move on to the stroke localization. So then we have not yet talked about the ischemic stroke treatment at all, which is really important for exams. But before that, let us talk about something with regards to the stroke localization. How do you localize a stroke? I mean, especially with regards to the ischemic stroke, which is going to be extremely common. Whenever I have a patient with a suspected stroke and probably coming with an acute onset focal neurological deficit, I have to first categorize into whether the patient is having an anterior circulation stroke or whether the patient is having a posterior circulation stroke. This is the basic triage kind of a thing. Posterior circulation stroke. Suppose if the patient is having anterior circulation stroke, I know that only one of the three arteries must be involved. Either it is the internal carotid artery, which is the mother of two more arteries, that is anterior cerebral artery and middle cerebral artery. So we know that ICA is going to be the mother of the other two arteries, AC and MCA. So the lesion must be somewhere in the ICA, AC, or MCA. As far as the posterior circulation stroke is concerned, it's a commonly called as vertebrobasilar system. So which means either the lesion will be in the vertebral artery or the lesion is in the basilar artery and its branches. And this is the vertebrobasilar system we are talking about. Or basilar artery finally bifurcates into two posterior cerebral arteries. So the lesion can be in the posterior cerebral artery. So these are the usual arteries that are affected in the setting of a posterior circulation stroke. But here are some common features between anterior circulation stroke versus posterior circulation stroke. In the sense, like if you have some clinical features, you can surely tell it's an anterior circulation stroke. If you have some clinical features based on anatomy, you can tell it is a posterior circulation stroke for sure. For example, so presence of hemiparesis. Listen carefully. Presence of hemiparesis can tell you probable anterior circulation stroke, but it's not sure because you need to evaluate for other features. For example, the question gives some features like aphasia or apraxia. And number 3, if the patient is having visual field defects, especially in the form of a homonymous hemianopia. Homonymous hemianopia. So if you have these kind of words, and if among the 3, if you have at least 2 out of 3, if you have, then that is called as a anterior circulation stroke. Basically, this is a very high sensitive finding, all these 3 findings. Suppose if you have any 2 out of 3, then surely you can tell that the patient is probably having an anterior circulation stroke. Suppose what the guidelines are telling is if you have only 2 out of 3, then it's called a partial anterior circulation stroke. If you have all 3 out of 3, then it is called a total anterior circulation stroke. That's called a TACS. But nevertheless, so out of these 3, if you have any 2 at least, then it will be called as an anterior circulation stroke. As far as the posterior circulation stroke is concerned, you have some 3 to 4 findings are there, which can tell you it's a posterior circulation stroke. The number 1 first finding is the patient is showing some symptoms or signs of syncope, or if the question tells you loss of consciousness, or the patient presents with features called drop attacks, which are nothing but syncope only, but called in a different way, drop attacks. So then in this settings, or severe vertigo, in this setting, I'm going to think about a posterior circulation stroke. So many students do ask, like, sir, if the patient comes with LOC, can I think about posterior circulation stroke? I'm not telling that because the differential diagnosis of LOC and syncope is huge. But if you're thinking about a stroke, then you can think about a posterior circulation stroke. That's all. Syncope has many causes. But if you think the cause of the patient's syncope is a stroke, then in that setting, you can think about a posterior circulation stroke because you won't get this in the anterior circulation stroke. Because only in the posterior circulation, your reticular formation is located, and the cerebellum and all these things are located in the posterior circulation only. So you're going to get this only in the posterior circulation stroke. Then you can develop something called a element cranial palsy. So please, you have to be a little careful. We are talking about a lower motor neuron cranial palsy, not an upper motor neuron cranial palsy. If you have an element cranial palsy, then probably you can think about a posterior circulation stroke. Then visual field defects in the setting homonymous hemianopia. Homonymous hemianopia, even that can tell you that the patient is having a posterior circulation stroke. Clear? So what are the guidelines telling? That among these 3, if only 1 out of 3 is there, then you can surely tell it's a posterior circulation stroke. Which means if you have only L11 cranial palsy, then of course, yes, you can tell the patient is having a posterior circulation stroke, and that is a very important point as well. And that's a very high yielding point. Only isolated lower motor neuron cranial palsies can be called as posterior circulation strokes. Yes, same VFD. So how can you understand here is, if I get only homonymous hemianopia in a particular patient, but I'm not having anything else to substantiate that the patient is having a anterior circulation stroke, because to tell anterior circulation stroke, you need 2. If I have only VFD, and if I don't have hemiparesis or apraxia, it's better to call that stroke as a posterior circulation stroke. Clear? Do you understand? So, I mean, first of all, you need to tell the basic differences between the 2. So when you call anterior circulation stroke and when you call a posterior circulation stroke. Let me tell the patient is having element third nerve palsy, plus hemiparesis, contralateral hemiparesis. This will be anterior circulation or posterior circulation? Anterior or posterior? This will be definitely a posterior circulation stroke because I have an element cranial palsy, which is a very important finding in a posterior circulation stroke. But if you suppose if you think this as an anterior circulation stroke, you have hemiparesis, all right. You have hemiparesis, but where is the other criteria to tell that it's anterior circulation stroke? Which means just hemiparesis alone, with it you cannot tell it's an anterior circulation stroke. You need to have something else. You don't have something that's something else. But for the posterior circulation stroke criteria, you have the proof that it's an element cranial palsy is there. So surely this must be a posterior circulation stroke. Now I think you'll be able to tell what is anterior circulation, what is posterior circulation. This is how you answer. For example, if the patient is having hemiparesis with Broca's aphasia, what is this type of stroke? This anterior or posterior? This is basically an anti-circulation stroke. Without a doubt, this must be an anti-circulation stroke. We know that. So because the patient is having both the criteria that is matched, very commonly you will get hemiparesis, Broca's aphasia, isn't it? So that's an anti-circulation stroke. All right. So first you have classified. So whether it's anti-circulation or a post-circulation. But let us see what are the new terminologies that we have introduced in this particular section. So I usually take my class in that direction only because you have introduced some new terminology. Shubham is asking visual field defect plus LM and cranial plus hemiparesis. It goes towards posterior circulation only, of course. Because according to the rule, LM and cranial palsy alone is enough to tell it's a posterior circulation stroke. So that is definitely a posterior circulation stroke only. Hemiparesis and visual field defect, I go for anterior circulation stroke. It cannot be a posterior circulation stroke because you have two things that match the anterior circulation, but one thing that matches the posterior circulation. So next question, hemiparesis with loss of consciousness. So in this setting, LOC alone can tell it's a posterior circulation. So I'll be predominantly thinking about a posterior circulation stroke only. Hemiparesis can happen in a posterior circulation stroke. So because LOC is matching the posterior circulation, only one is enough to tell it's a posterior circulation. So then I'll be calling it as a posterior circulation stroke only. This is only a prediction, not confirmation. Devi Krishna is asking whether it's a prediction or confirmation. Remember, how can you confirm by just a clinical characteristic? Clinical like knowledge can help you to predict something. It cannot be helpful in confirming something. There are a lot of areas where clinical predictions can go wrong. So you cannot really tell for sure that if this is there, then it's a posterior circulation only. No, we just predict. Probably if this is there, then it could be a posterior circulation. So it's just an anatomical understanding. That's all, based on certain set of factors. Hemiparesis, loss of consciousness, visual field defects. Monica is asking posterior circulation stroke because I have LOC, I have visual field defect. So only one is enough to tell it's a posterior circulation. So of course I'll go towards the posterior circulation. That hemiparesis does not tell that it's surely anterior circulation because hemiparesis can happen in posterior circulation also. ACS and can anterior circulation stroke and posterior circulation stroke happen together? Rare, but we call something as watershed infacts, which we'll be discussing subsequently, where infacts can happen in the watershed areas where there is an overlap between MC and PC territory. But apart from that, both can happening together is extremely rare. Hemiparesis plus aphasia plus LM and cranial nerve defect. So this is quite intelligent. Hemiparesis with aphasia with LM. But first of all, you need to understand the anatomy properly. So you're getting hemiparesis and aphasia means you're getting a cortical lesion. I mean, the sense like aphasia should be a cortical lesion. And whenever you want to get an LM and cranial palsy, you should get a brainstem lesion or probably somewhere in the posterior circulation only. So which means you are actually combining an anterior circulation stroke with a posterior circulation stroke. And I told you already it's extremely rare. So if you want to get aphasia, it's a cortical lesion, anterior circulation. And if you want to get a LM and cranial nerve defect, it must be in the brainstem. It's a posterior circulation. So which means you need to involve an anterior circulation artery and a posterior circulation artery. Both should be there. Then only you can get the situation what you're talking about. So then, which means your anatomy is very weak there. That's what it means. So that combination is very unlikely what you have given. I can give a combination whatever you want. So what if hemiparesis, aphasia, visual field defect, syncope, LM and palsy is there? Give that kind of a presentation. Like, why you are left only with that? So you can give any presentations, but this is only a prediction, first of all. I mean, this will give you an introductory idea about what's happening over there and to tell whether it's really an anterior circulation or posterior circulation in an overall prediction. So this is how it's going to be. So based on that, and this is not confirmatory. Of course, I'm going to a CT and MRI if I'm really thinking about that. Uday Bhaskar is saying, nice laugh, man. Okay. Okay, I don't know what you mean. You really mean it or you mean it in a mean way? Okay. You have anterior circulation and a posterior circulation stroke. This is a real criteria or a trick? Okay, he really means it, but not in a mean way. Ishan is asking, is this a real criteria or a trick? You can remember as a trick, but you have a classification. Oxford classification is just an extrapolation of what Oxford classification tells. But you can identify as a trick also, because I'm going to give a lot of tricks in understanding strokes. Riju is asking what is hemianopia. Okay, fine. So let us take all these things into. Oh, you're asking why hemianopia. Okay. So let us, study one by one. So because you have a lot of new terminology that are introduced here. So that's what I was about to tell. So you have a homonymous hemianopia. So a new terminology we have introduced, and we have introduced aphasia and apraxia, new terminologies. So you really need to know about that. So what is aphasia? What is apraxia? What is homonymous hemianopia? I'm not going to teach you proper ophthalmology, but this will help you. This is how we understand the visual field effects. For example, as per the visual fields are concerned, everything in the body generally crosses when it comes to the brain. So which means this crossing is 100%. Nothing escapes from this crossing. Evolutionary theories are bamboozled really. They can't really tell one concrete reason why the crossing is really happening. For example, whatever is present on the left side goes to the right side of the brain. Whatever is present on the right side goes to the left side of the brain. Even vision is not spared. Even hearing is not spared. And as per the Darwin's theory, anything that is present and it is consistently present throughout generations means that should have some advantage. Otherwise, that doesn't make any sense and that will go extinct. That's what Darwin's theory tells. And we couldn't really understand. There are a lot of theories behind that, but there is not even a single concrete reason to tell that why this crossing happens. What kind of evolutionary advantage that this crossing provides us. But nevertheless, everything crosses. That's the take-home point here, including vision. So in the sense, like whatever you see on the left side goes to the right side, and whatever you see on the right side goes to the left side. So this is my simple understanding, and don't ever confuse me with your retinal fibers and all these nasal temporal fibers. I know you guys, especially the second year and final year guys, will be very thorough in the retinal and nasal fibers, and you would have studied in and out in person, or probably Kansky, or probably one more Indian book is there. Whatever book you have studied, that's fine, keep it with you. But my understanding is very simple. Whatever I see on the left side goes to my right occipital cortex, and whatever I see on the right side goes to my left occipital cortex. And that's how it is, and that is the basis of all these fibers also. Based on that only, okay, Kurana is the Indian book. I forgot. Okay. My favorite book for Opthal is Kansky. Kansky is a very good book basically, but even though it's exhaustive, but it gives a very good information. I, for some reason, don't like Person that much. So Kansky is a very nice book. It will be like more of a storytelling kind of a book. Person is so concentrated. I don't feel it's good. Riju telling Soch. I'm not commenting on Soch, but it's a MCQ book. Review books. Okay, that's why. Shum is telling I like Kansky right recently. How can you read these many books? No, it's not about reading these many books when you get time. So again, it's the consistency that matters. I don't have any plan on my own. Like I don't really make a plan that today I need to read this, tomorrow I need to read this. Just what I do is like I just take a text during my UG days, not now. During now I am having a very perfect plan that I need to do this. During my UG days, I generally take some book, and I'm very sure that I need to read for 2 hours. That's all, just 2 hours. I make sure I read it some point of time, like 8 to 10 or 7:30 to 9:30 or even 9 to 11 or 10 to 12, doesn't matter. That 2 hours daily is mandatory for me. Otherwise, I'll feel that day is incomplete. Remaining time, whatever you want, you can do. Not a problem. Samira is asking hemiparesis plus LOC plus aphasia. I told you already. I mean, this is only going to give an overall idea about where is the stroke. It's not going to confirm where is the stroke. I mean, these kind of things can happen. Okay. Soch is a very good review book. I have never read that, sorry. So I cannot comment on that, but it might be a very good book. Fine. Cool. What else you're talking about? Yeah, homonymous hemianopia. I told you everything crosses. Left side goes to the right occipital cortex, and whatever you see on the right side goes to the left occipital cortex. So in a understandable way, if you want to tell. So for example, if you take the visual fields, this is what the patient sees. Remember, this is not the patient's eyes. This is what the patient sees, basically. Let me divide into left and right. So for example, whatever the patient sees on the left side, whatever patient sees on the left side they have to move towards the right occipital cortex. Right occipital cortex. I mean, I'm talking about the visual fields here. See, please understand, I'm not talking about the retinal branches. So whatever is you on the left side goes to the patient's right occipital cortex, which means this is the left temporal field and probably a right nasal field. You're talking about only visual field effects, only visual fields. Then you have this kind of right-sided visual fields. For example, your right temporal, sorry, no, it's not right temporal. This is left nasal field. Left nasal field and right temporal. And whatever drawn in pink here are going to be important for your right-sided vision. So which means the left eye nasal field is the one that's going to look on the right side, and your right eye temporal field is going to look on the right side. So these two fields has to go to the left occipital cortex. That's all. So this is a very simple view, and this is how it works basically, and that's how your fibers are also arranged. That's all. So now let us understand the crossing. I mean, how it happens. So if you take whatever may be the case, the basic reason for crossing is, I told you, it is the visual fields have to cross, which means whatever you see on the left side has to go on the right, and whatever you see on the right side has to go on the left. So this is the reason for the crossing in the first place. So I don't want the fibers at all. So this is the area of the optic chiasma. And after the optic chiasma is over, this optic tract is going to enter the thalami. And in the thalami, which area? There is some geniculate body, isn't it? What is that? Yes, that's a lateral geniculate body. So that's where in the thalamus. And I'm not worried about the anatomical arrangement right now. So because there are a lot of fibers within the lateral geniculate body, and there is a different type of anatomical arrangement depending on whether it is superior fiber or an inferior fiber. I'm not worried about that right now. And these thalamic fibers are going to radiate from the thalami. Yeah, so that's why I don't want that right now, Riju, because that's going to only confuse. So this radiation is what we refer to as something called an optic radiation. And ultimately, they are going to end up in the occipital cortex, right and the left occipital cortex predominantly. So remember, this is basically coming from the right eye, for example, and let us assume this is coming from the left eye for that matters. Suppose if I put lesions at different areas. For example, let me assume that I'm putting a lesion in the pre-chiasmal pathway. So if my lesion is in the pre-chiasmal area, I know very well I'm going to have an ipsilateral eye involvement, ipsilateral blindness most of the time, or ipsilateral loss of vision, and problem is going to be only on the ipsilateral side or only one side if I'm going to have a pre-chiasmal lesion most of the times. Or if I'm having a chiasmal lesion, or if I'm having a post-chiasmal lesion. Let me talk about a post-chiasmal lesion first. Suppose if I'm having a post-chiasmal lesion anywhere, here, here, here. So I'm having a post-chiasmal lesion. So what will happen in case of a post-chiasmal lesion? Anywhere. Post-chiasmal lesion can be in the optic tract, or post-chiasmal lesion can be in the thalamus, or post-chiasmal lesion can be in the optic radiation, and post-chiasmal lesion can be in the occipital cortex as well. As per my understanding, once the crossing has happened, so you can see this is where the crossing has happened. So once the crossing has happened, if I put lesion anywhere beyond the crossing, that will be involving only visual loss of, I mean, with the sense like that field loss will be there on one particular side. So which means the reason for why this crossing has happened is because I need to take the left-sided vision to the right side and right-sided vision to the left side. So which means once my crossing has happened, beyond that, if you put lesion anywhere in the optic pathway, I'm going to result in only one thing. My contralateral side of vision will be lost, which means only one side. For example, if this is a right-sided lesion, in this particular example, I'm putting a right-sided lesion, so which means I'm going to have a left-sided homonymous hemianopia. Homonymous hemianopia. That is the idea. So what do you mean by homonymous hemianopia? Which means if you're losing vision only on the one side. For example, if you have a visual field like this, you lose either a left-sided vision or use a right-sided vision. So which means this is the typical example of you're losing a left-sided vision, which means you have lost everything on the left side. So that is supposed to go to the right occipital cortex, which means it's the left temporal that you have lost and the right nasal field that you have lost. That's all. So in the sense, like whatever you have lost is typically only on one side. It's not on both sides. You lost only on one side. So this is a typical example of a homonymous hemianopia. That's the reason why you get homonymous hemianopia. Once after the crossing, your lesion is there, means that one particular side of the world will be completely gone out of the picture. So that is what we refer to as a homonymous hemianopia. But on the other hand, if you get a prechiasmal lesion, I know my lesion is going to be something like this. This is going to be my prechiasmal lesion, basically. So which means I'm going to lose vision on one particular eye. That's all. Similarly, if I have a chiasmal lesion, we have different types of chiasmal lesion. Like we have a central chiasmal lesion, we have a lateral chiasmal lesion. Doesn't matter. If you have a chiasmal lesion, for that matters, you're going to result, because it happens at the time of crossing, at the site of crossing it happens. So it doesn't respect that left side or right sided rule. So you will get visual loss on the left sided visual fields, as well as you will get visual loss on the right vision also. Or it can be like this also. For example, you can get visual loss in one eye on one side, and you will get a visual field defect on the other eye on the other side. Which means here, if you see in the left eye, left side vision is lost. In the right eye, right side vision is lost. In this example, second example, in the left eye, right side vision is lost. In the right eye, left side vision is lost. So this kind of hemianopias is what we refer to as something called a heteronymous hemianopias. Heteronymous hemianopias. So I can basically classify my visual field defects into three: prechiasmal, chiasmal, postchiasmal. Prechiasmal will have one side, only ipsilateral eye will be gone. Postchiasmal lesions, only one side of the world will be completely gone. That is called homonymous hemianopia. And in chiasmal lesions, I'm going to get both side world vision loss. That is either a bitemporal hemianopia or a binasal hemianopia. So we know this is what we refer to as the first one is the bitemporal hemianopia, and the second one is a binasal hemianopia. Fine, understood. So that's quite simple as well. It's not a very difficult thing. So basically you need to localize where is the lesion. So chiasmal, prechiasmal, or postchiasmal. So this is how you localize. Then you have a lot of internal things within that. For example, where you will get a bitemporal hemianopia is a question. So bitemporal hemianopia typically you will get in a central chiasmal lesion. We know it's a chiasmal lesion, but bitemporal hemianopia happens typically in a central chiasmal lesion, which means if the defect is in this location, you will get a bitemporal hemianopia. That's because then nasal fibers are the ones who will cross. I mean, I put a correct image only for your understanding. The nasal fibers are the ones which will cross, which basically take the temporal field of vision. So that is why in a central chiasmal lesion, the nasal fibers will be lost. That is typically going to affect the temporal fields, and you will get a bitemporal hemianopia in that setting. So which means it's a central chiasmal lesion. And in that itself, we have two different groups I told you. One is whether you will get superior more than inferior or inferior more than superior. If at all your superior vision is affected more than inferior vision, you know, in this setting, you are going to deal with a pituitary lesion, or for example, a pituitary adenoma. Suppose on the other hand, if your inferior vision is affected more than superior vision, you are dealing with a probable craniopharyngoma or a hypothalamic lesion. Craniopharyngoma or some hypothalamic lesion, we know that. So this is very simple to understand, because the visual fields not only flip in left to right direction, the visual fields are also going to flip in up and down area. So top, bottom, in this region also the visual fields are going to flip. So why that should happen, again, it's a matter of debate. But initially we thought that because your lens that is seen in the eyes is a convex lens, that's a biconvex lens, it produces a real image, but basically it produces an inverted image. So probably this is brain's one way to, produce an inversion again as a projection in the cortex, so that otherwise every image will be inverted like this because of the convex lens that you have. So this is one way where the fibers itself invert one more time, so that the projection in the cortex will be upright, straight, so that you are able to see everything in the like upright posture. So, I mean, even though that theory is bashed now, but anyway, you can understand like that. So, which means the fibers that are carrying the inferior world will be flipping up and going on the top direction, and fibers that are carrying the vision from the superior world, up, what you see on the upper side, will flip and come down in the lower areas when they go through the optic tract. So that is why whenever you compress something from the bottom, like for example, a pituitary adenoma, like pituitary is here, then optic chiasm will be here, and on the top you have hypothalamus and all these structures. So pituitary tends to compress the chiasm from the bottom. So if you produce a central lower chiasmal lesion, then you know that because of this flipping, the superior world will be coming through the lower part. So superior vision will be affected more. And second, if you have a craniopharyngioma that compresses from the top, so in that setting, you know very well that the upper fibers will be affected that are basically carrying the vision from the lower part of the world. So that's why your inferior loss more than the superior loss means it's craniopharyngioma, usually in exam, and superior loss more than inferior loss, it's very likely to be a pituitary lesion in exams. Typically in binasal hemianopia, you will be encountering in a lateral chiasmal lesion. Lateral chiasmal lesion. Very unlikely to get a binasal hemianopia, but anyways, so this has been described in certain situations where you can get aneurysms of the internal carotid artery. For example, if there is a bilateral aneurysm of the internal carotid artery, that can affect the lateral part of the chiasma. So in which world you will get a bilateral internal carotid artery aneurysm? Usually it's very rare to get a bilateral IC aneurysm, but one condition that has been proposed to cause a bilateral internal carotid aneurysm is the cavernous sinus lesion. So because of cavernous sinus lesions, you can get a bilateral ICA, because cavernous sinus tend to be connected with each other, and once one cavernous sinus is affected, very commonly other thing also will be affected. So you can get a bilateral weakening of the ICA wall, so that can produce an aneurysmal enlargement resulting in compression of the chiasma from the lateral aspect, resulting in the development of a lateral chiasmal lesion producing a binasal hemianopia. So now you know. Bitemporal central chiasmal, binasal means lateral chiasmal lesion. So pre-chiasmal we know, chiasmal we know, post-chiasmal also we know, but how to tell where the lesion is in the optic tract, or how to tell whether the lesion is in the optic radiation, or how to tell whether the lesion is in the occipital cortex. So for that we need to know the lesion is congruous or incongruous. So there is a common rule that as you move down towards the posterior side, from anterior to posterior, from optic tract towards occipital cortex, the lesion tends to become more congruous in nature. So in the optic tract, it's going to be most incongruous, but as you move towards the posterior side, towards the occipital cortex, it's going to be more congruous in nature, which means the lesions that happen in the optic radiation or probably in the occipital cortex is going to be more congruous in nature than the lesions that happen in the optic tract or in the thalamus. Optic tract and thalamic lesions usually will have more of a incongruous lesion only. So what do you mean by incongruous lesion? So whatever I drawn here are an example of a congruous lesion. So now let us see what you mean by incongruous lesion. For example, if you have a lesion like this, you have a homonymous hemianopia only, which means you are having same side world involvement only. Let us assume this is a kind of lesion you got. This is a kind of lesion you got. So this is basically a homonymous hemianopia. There's no doubt about that. Homonymous hemianopia. But you're seeing a lot of unequal defects, in the sense like both are not actually symmetrical. So these kind of unequal and not symmetrical visual field defects are what we refer to as incongruous type. So whenever you see more of a incongruous type of homonymous hemianopia, the lesion is usually located in the optic tract, or probably it can be located in the thalamus. But usually more often it localizes a lesion to the optic tract only, because thalamic lesions will have other issues. Whenever the lesions are in the thalamus, you will have associated hemisensory loss, associated pain, associated burning sensation, and other features will be there if there is a thalamic lesion. It's not only an incongruous homonymous hemianopia, but along with that, there will be associated other problems also, because thalamus is a relay center for many senses. There will be an pain, burning sensation, all these things. But if the lesion in the optic tract is isolated, but it's very rare, it can happen in the setting of probably a multiple sclerosis sometimes, but it's very rare. But usually encounter lesion in the thalamus only. But easily you can find out because you're going to have other associated problems in this condition. Or if you get a congruous lesion like this, when you're going to get a congruous lesion, which means you're going to get a contralateral homonymous hemanopia, which means it's going to happen only on one side, but you are more having a congruous lesion, which means equal lesions. Even this is a congruous lesion only. And congruous means it just means it's equal lesion. Even this is a congruous lesion only. So there is also contralateral congruous type of hemanopia only, but I mean, it is a type of homonymous hemanopia, but usually we call this as something called a quadrantanopia. Quadrantanopia. So this is also congruous lesion only. And in fact, this is also type of hemanopia only. This is not a this type of homonymous hemanopia only. This is not a heteronymous because only one side, one particular side of the world is involved. So it's also type of homonymous hemanopia only. On the other hand, if you see this kind of congruous lesions, contralateral homonymous hemanopia. So in this particular setting, I will be thinking about more of hospital cortex lesion. But one more clue with regards to the hospital cortex lesion is I'll be having something called a macular sparing. So the macula will not be involved. That's really important because we know macula is basically supplied by both the posterior cerebral arteries. So one side PCA in fact will not affect the macula unless until both the PCA lesions will have a typical entity called a macular sparing. So that's very characteristic. And whenever I have a quadrantanopic type of lesions, I mean, remember, please be very careful in exam whether this kind of quadrantanopic lesions are homonymous or heteronymous. Please be very clear. Sometimes this superior more than inferior that you get in chiasmal lesions, they can also give kind of a quadrantanopic lesions. Remember, if the quadrantanopic lesions are, like heteronymous, which means two different sides of the world are there, even if they give the word quadrantanopia, you should not go to that. You should see whether it's homonymous or heteronymous in the first place. Heteronymous quadrantanopic lesions go to chiasma only. You have to localize the lesion in the chiasma only. Homonymous quadrantanopic lesions only will localize the lesions in the optic radiation. So which means still this quadrantanopic lesion should be homonymous. If it's heteronymous, it will go towards the chiasmal lesion. If it's a homonymous quadrantanopic lesion, then only you can tell this in optic radiation. Because the moment you see quadrantanopia in exam, immediately you think about the optic radiation only. You will be localizing either in the temporal lobe or you'll be localizing in the parietal lobe. So don't do that. So see whether it's homonymous or heteronymous. If it's homonymous, then you go for optic radiation. In the optic radiation, there are two optic radiation are there. Like this superior fibers and inferior fibers. As I told you that fibers that are carrying the upper part of the world and lower part of the world tend to separate out. For example, this superior fibers that are carrying the inferior world. Superior means upper fibers that are carrying the inferior vision is basically going through the parietal lobe, which means that's a natural rule that when they move, the superior fibers go through the parietal lobe, but these superior fibers are basically carrying the information from the inferior part of the world. So these fibers are what we refer to as a bombs loop. And similarly, this inferior fibers, we know that they are going to be going through the temporal lobe, and we know that inferior fibers are going to go through the temporal lobe. These inferior fibers are the ones that are carrying the information from the superior part of the world, but still they are inferior fibers. They'll be going through the temporal lobe, and these fibers are called as Mayer's loop. These fibers are basically called as Mayer's loop. So now, if I have a mnemonic for that as well. So optic radiation lesions, the mnemonic is basically PITS, or you can remember like pie in the sky also, but I used to remember by the mnemonic called PITS. What do you mean by PITS? So parietal lobe involvement means they will have inferior vision loss, and temporal lobe involvement means I'm going to have a superior vision loss, basically, which means this kind of visual loss will go towards a temporal lobe involvement. because I'm losing a superior vision. So this is a superior homonymous quadrantanopia. If we have a lesion like this, inferior lesion, still it will be on the contralateral side only, on one particular side of the world only. So this is an inferior vision loss. So must be superior fiber involvement in the MCOMS lobe, in the parietal lobe. So it must be a lesion in the parietal lobe. So you can remember with the mnemonic called, I remember with the mnemonic called PITS, that's pie in the sky is also fine. So where parietal lobe means inferior vision loss and temporal lobe means superior quadrantanopia. So now we know how to localize the lesion based on our basic understanding. I didn't do anything at all. I didn't talk about the nasal fibers. I didn't talk about the retinal fibers, temporal fibers, nothing. So it's just based on the visual field, how they are crossing, whether you see a chiasmal lesion or a pre-chiasmal lesion or a post-chiasmal lesion. Chiasmal, heteronymous, pre-chiasmal going to be unilateral involvement, post-chiasmal, homonymous. Based on congruous versus incongruous, you can tell more anterior or more posterior. Based on macular sparing, you can tell whether it's occipital cortex or optic radiation. In the optic radiation, based on whether it is superior or inferior, I can tell whether it's a parietal lobe involvement or a temporal lobe involvement. Based on chiasmal lesion, whether it's bitemporal or binasal, I can tell whether it's a central chiasmal lesion or a lateral chiasmal lesion. Based on whether it is superior more than inferior or inferior more than superior, I can tell whether it's a parietal, it's a pituitary lesion or a hypothalamic lesion. I think, hope this is easy for you. Like that's how I remember visual field defects. This is my way of remembering it in a much easier way rather than confusing it in a big time. Do you understand? Cool. Yes, that's all. No need to confuse. This much is more than enough for exams, and even for your day-to-day practice, this is more than enough if you want to practice as a physician. Suppose if you want to become an ophthalmologist, then you need to know some extra things, because within the chiasma itself, there are multiple small lesions are there which you might need to be knowing. But if you're not going to become an ophthalmologist, if you're not practicing ophthalmology, then that is not really needed for you. So yes, of course, I know the visual field defects. Now, my next statement is I need to know about these two statements, because I gave another new word on aphasia and I give another new word on apraxia. So I'm going to discuss on three things. What do you mean by apraxia? What do you mean by agnosia? And what do you mean by aphasia? There are three words that you need to remember. Superior is parietal. Ashwin is asking superior is parietal, then why did you said pituitary? Day. Superior parietal means I'm talking about the optic radiation. In the chiasma itself, you're having superior and inferior separately. So chiasma, you have superior and inferior. And that comes to the thalamus, and after thalamus, it goes into optic radiation as superior and inferior through the parietal and temporal lobe. So you're actually confusing this area superior and inferior with this area superior and inferior. So don't confuse with that. Completely different. That's all. It's as simple as that. No need to worry about that. Then what about other things? We have been talking about aphasia, apraxia, and agnosia. First, let me tell what do you mean by agnosia and apraxia. Let us oversimplify it first. What do you mean by agnosia and what is apraxia? Whenever I use the word agnosia from now on, it will be a problem of identifying things. For example, I cannot identify something. When I can see this, there is some keychain over here, but I am not able to identify this. This is a keychain. So probably I might be having some problem in the vision. So that's a visual agnosia. Suppose if I'm not able to touch something and identify. For example, I'm seeing this, I can identify this is a mobile phone, but I am not able to identify on touching and seeing what is this. Then it is a visual, the sensory agnosia. Maybe that's why we call it as something called a astereoagnosia. That's a sensory agnosia. Similarly, you have multiple different types of agnosia. People can have a problem in identifying only selected things also. For example, there is one syndrome called Jesman syndrome where the people are not able to identify only fingers. That's called a finger agnosia, which means there are some specialized areas in the brain that are important for identifying some specialized things. So if you have problem in those areas, you will not be able to identify those things. So that is what we refer to as agnosia in the first place. And what is more important in understanding agnosia and apraxia is, this is something that you don't, I mean, you have learned already and you have forgot what you have learned, or if you are having difficulty in identifying things that you have learned already, which means I know throughout my life I have seen the pen in my life, and suddenly I'm not able to identify that this is a pen. So this is agnosia, which means I know that this is a pen already. So I've learned all through my life. Suddenly I'm not able to remember that this is a pen, or I'm not able to identify that this is a pen. Then it means definitely it's an agnosia. When you get a new thing that's different, that's a learning experience. Riju is telling, I'm suffering from MBBS agnosia. You have forgot why you took MBBS, probably. That's frustration, not agnosia, Riju. Okay, that is frustration that is coming out of you. That is normal. That happens in many medicos' life. And I think probably, like at least our generation is okay. Even our generation are suffering the heat. Considering your generation, I feel really bad for you guys, because there is too much of competition. Trust me, so much of competition is there. By the time you guys finish super specialty and come out, there's going to be a truckload of doctors out there, and everywhere it's going to be completely saturated. And at least you guys, like somehow you push in through. But imagine the guys who are struggling for the NEET UG right now, and by the time they come, you will be, like completely finishing them off. And there will be so much of doctors, and they wanted to, and every year, like 1 lakh FMG students are actually entering. Now it's becoming 1.4 to 1.5 lakhs of FMG students, coupled with that 1 lakh of Indian medicos. And I really don't know where is the place to go, even though they call everything in the form of doctor-patient ratio and all this stuff. But all this matters only when you have a sufficient infrastructure. Otherwise, it doesn't matter at all. Final year students are most frustrated now. Why final year students are most frustrated? What is the reason? How can we help us further? I don't know. You have to find your own way. Nevertheless, okay, no clinics. That's why final year students are most frustrated. Okay, cool. Whatever may be the case, let us go with our flow. So that is agnosia. So basically, you're not able to identify something which you are already able to identify things. So that is what we call it as agnosia. But in India, 1:1,000 doctor-patient ratio. Okay, fine. So now make it. Arshad is asking, it's 1:1,000. So make it 1:100. All right. What is the point in making 1:100 when you do not have an infrastructure? When you don't have facility to treat? When you don't have a CT scan machine in the periphery? When you don't have anything in your area? So what is the point in having 1:100 doctor-patient ratio? So actually, I feel it's a part of a cover-up from the government to increase the doctor-patient ratio without their ability and inefficiency to increase the infrastructure. So basically, when you want to improve the country, you need to improve the infrastructure first, then bring the doctors on. That's fine, that's cool. But if you do not have any infrastructure, just increasing the number of doctors will only increase the frustration among the profession. So a person who's working in the periphery, nevertheless, if he doesn't have any infrastructure, is going to refer the patient to the tertiary care center. Once the patient comes to the tertiary care center, and of course in the tertiary care center, it's going to be only a limited set of doctors who are going to occupy there. And the truth is, the person who's working in the peripheral center wants to come to the tertiary care center, and the person who's in the tertiary care center don't want to move their ass out anywhere else. So where this is going to end? Of course. Yeah, of course, when you increase the doctors, there are a lot of problems are going to happen. So without the infrastructure, because nobody wants to go to the periphery. Why nobody wants to go to the periphery? The main reason why nobody wants to go to the periphery is because there is no infrastructure there. Everyone knows that. If you ask a surgeon, so can you go and work in the periphery? Because there is so much of place there. If somebody asks about the doctor-patient ratio, so many patients are there. You go there and work there. What a surgeon tells, ultimately my hands will be gone because I don't have any infrastructure to operate there. That's the most important problem. So increase the infrastructure there. Obviously, these doctors are going to go and work there. And when you saturate the field, when you saturate the tertiary care centers, because there is so much of people already in the tertiary care centers, the tertiary care doctors' salary is also coming down greatly. Ultimately, your wages are also very, very less. And you need not give so much of salary. Ultimately, like you push doctors, you make them study throughout their life in the entrance race, and finally, like create their downfall. That's what is happening right now. And I don't know where this is going to end. Exactly. Doctor's condition will be same like engineers 10 years from now. That's a true statement. I don't know what's the name that is mentioned. That's a very true statement. Because in 2003 and 2002, when I was entering the college, if you see that time, engineers are regarded as one of the best professions. Like they will earn much faster. They will be telling doctors will take so much of time to earn. So engineering is a very attractive field. But remember, now many people are working in Swiggy because every area, every district has 10-15 engineering colleges. So that's where the problem is. Again, the medical colleges are also getting the same kind of this thing. I think in 10 years time, the grace will be gone completely. Now, everybody wants their kids to become a doctor, but definitely I won't do that mistake. I will just leave them my kids do, whatever they want to do, I'll make them do. But this is not going to sustain for long. This kind of giving money, somehow make them a doctor and come. Where is the place? Tell me the place to go. Where is the place? If you tell 1:1,000 is the doctor-patient ratio, make it 1:100, but still how they can treat without any infrastructure? Where is the infrastructure? Where will they get the job? Where will they get the satisfaction without treating a patient? Just giving amoxicillin, paracetamol, B complex tablet, how will they get their job satisfaction done after 10 years of time? Not possible. Okay. Nevertheless, let us move on and see what do you mean by apraxia. So can anyone tell what do you mean by apraxia? Because we know that agnosia is a problem of identification. So what do you mean by apraxia in that sense? Yes, that's correct. Extremely correct. Alex is telling that inability to do a learned motor activity. I mean, with normal power, I won't really agree, but power doesn't matter. That's the correct statement. Yeah, apraxia means you can imagine like a problem of execution. You cannot execute something. Like for example, if I want to take this water bottle and open it and I want to drink it, there are multiple sequence of events that is involved in this opening the bottle and drinking the water. It's not like a simple task. It's a very complicated task. Basically, like you might be thinking it's simple, but considering the evolutionary perspective, humans are so advanced that this is an extremely complicated task. I mean, try to teach similar things to a dog or try to teach similar things to a monkey, you will understand the frustration, how difficult it is to do these kind of tasks. So it needs a lot of complicated process, sequential coordinated movement of muscles. And for that coordinated movement of muscles, there should be a sequential implementation of programs within the basal ganglia and the cortex. So then only I'll be able to do this movement. If you have any problems in this area, the circuitry is not working. So then I'll not be able to do that. So if I'm confused on how to do this particular task, so then that will be called as a apraxia. Remember, many people are telling in the absence of weakness in the presence of normal power, it doesn't really matter according to me, because whether the power is normal or abnormal doesn't matter. I'm not able to do this. That is the idea here. Without power, if I'm not able to do this, that is a weakness. That is different. But still, I'll be knowing how to do that. And I will be able to perform if my power is good. So power loss will not be the key feature here, because many times in the stroke, there can be an associated power loss. So you should not confuse with that. So what I'm trying to tell is this inability to perform a learned motor activity is completely different from my power loss. So that is unrelated to my power loss. It can be, there can be a associated power loss, or there may be a normal power also, but I'm not able to do that. That's the most important thing. So I'm not able to execute. So you can tell in two simple words, in a very simplified fashion. Agnosia is a failure of identification, whereas apraxia is a failure of execution, or apraxia is a failure of executing a learned motor activity that is already known by me, but I'm not able to do that right now. So, all right. So we know what you mean by apraxia and what do you mean by agnosia. There are a lot of types of agnosia, as I told you: sensory, visual, auditory. So many types of agnosia are there where I'm not able to identify stuff. Apraxia, as far as I'm concerned, I have many different types of apraxia, like gait apraxia, then gaze apraxia is there. Then you have limb kinetic apraxia, ideomotor apraxia, ideational apraxia. So many different types of apraxia. All these things are telling only one thing: I'm not able to execute something. Yeah, construction apraxia is there. So I'm not able to execute something, a motor activity, which I've already known it. But this is not implicated by loss of power, or this is not due to loss of power. That's all. So based on this, I can go to the next thing, that is aphasia. So this is the most important topic in your exam as far as the entire your practice, this aphasia is going to be very, very important because you need to identify this aphasia. That's why we're going to discuss this aphasia in a little bit of depth and detail because very common questions in exam. So we have a traditional model, how speech works and language works. But before that, I wanted to warn you telling that this traditional model is no longer a correct model, but even though it will help you in understanding. So what are the things that are going on in the brain? And even before going into aphasia, it is important to note that there is something called a dominant hemisphere and here something called a non-dominant hemisphere. Remember, dominant hemisphere always means the left hemisphere, usually, because in 97% of the times, I mean, in Indians, it is almost 99% of the times, 97 to 99% of the times, the dominant hemisphere is always the left hemisphere. Very rarely only the dominant hemisphere will be the right hemisphere. And remember, this dominance is not related to the handedness. Remember, there can be 20 to 30% of the people who will be left-handed, and 70 to 75% will be right-handed basically. But in India, the proportion of having left-handed individuals are much, much lesser, maybe only 3 to 5%. The reason is because in India, left hand is considered to be inauspicious, and it's been found out that many of the parents purposely they convert this left-handed guys to right-handed guys. I mean, that's what is happening for a long time. But nevertheless, the left-handedness will be around 20-30% usually, and right-handedness will be around 70-80% basically. But this is not related to dominance. Handedness is not equal to dominance. Dominance is completely different, which means a certain set of functions will be done by one hemisphere. And if that certain set of functions are done by the left hemisphere, that will be the dominant hemisphere. So most of the times that certain set of functions are done by the left hemisphere only. Let us see what are those functions. Number one, the most important thing in that is the speech and the language. Speech and language. This is going to be really, really important, especially when they talk about language. It's always about the dominant hemisphere. And remember, if language is done by the right hemisphere, then that will be the dominant. I'm not denying that fact, but 99% of the times, your language is actually taken care of the left hemisphere only. That's why it's the dominant hemisphere. Then apart from that, you have calculation. Your arithmetic ability. Calculation is basically done by the dominant hemisphere only for sure. There's no doubt about that. And apart from that, you have other things like writing. What I'm doing right now is also done by the dominant hemisphere only, without a doubt, surely. So what are the other things that are done by the dominant hemisphere? Any idea? Yeah, logic. That I would probably call as a judgment and abstract thinking. Can anyone tell what do you mean by abstract thinking? Judgment and logic, yes. Abstract thinking is not only probabilities. Everyone, like immediately they're telling probabilities. No, you're understanding, respond to a puzzle. Okay, not like a puzzle. You're actually telling the literal meaning. The way to test this kind of abstract thinking is what you're trying to tell. But 111 told correctly. That is actually a rational thinking. Writing, you said handedness not including dominant. No. Handedness is different. Remember, I can be right-handed or left-handed. I can write in the left hand, but still my dominant hemisphere may be left. So which means what I'm trying to tell is my ability to write will be coming from the left hemisphere only, even if I'm left-handed. But that will give signals to the right hemisphere, and that motor cortex will stimulate my left hand to write. So which means the origin of writing is from the dominant hemisphere only. That is the most important thing. Think out of the box. You're telling about thinking out of the box. Okay, fine. So what do you mean by abstract thinking? It's a very simple thing. For example, it's very important in day-to-day life also. For example, I'm telling, okay, yesterday somebody told, let us take that into perspective. Boys like curves. Who told that? That fellow is there here. Young boys like curves. I think one fellow told yesterday night when I was about to sleep during that time. Who's that? That fellow is not there, I think. So he's the one who told, like, yes, boys like curves. And especially young boys like curves. So what does it mean? You know, like young boys like curve means a person who has lost his abstract thinking capability, he'll be thinking like young boys like curves. So these are the curves he's talking about. So, but what curves we are talking about, everyone knows here. So this is abstract thinking. That's all, as simple as that. So which means abstract thinking is something that is present in our day-to-day life. everywhere, not only here. So indirectly, when you want to test a person, you test in the form of a proverb. That's all, nothing else, because proverbs tell something indirectly, right? So we know the meaning properly. So it's like that, but that's for testing. Yeah, probably sarcasm. I mean, it's like it's in day-to-day life, not only sarcasm, a lot of areas. There is a lot of hidden meanings in whatever we speak. Like we don't speak straight. So for example, you're telling home, like you tell, I'm thirsty, bring the bottle. So if somebody goes inside the kitchen and if they bring the bottle only and give it to you, how bad, how angry you will feel. So you're telling you're thirsty and bring the bottle means, what does that mean there? That's an indirect meaning, like you need water, that's all. That's understandable. So this is something we acquired with our peer mates, we acquired with our friends, we acquired with our communication with our parents, and we know what we really mean, and even others know what we really mean. So that's what we refer to as abstract thinking. This is very, very important day-to-day life. It's not only for sarcasm, not only for proverbs, it's there hidden everywhere. So in our routine day-to-day conversation, that abstract thinking is very, very important. So when you're going out, for a country that believes in God, rational thinking is not possible. Of course, yes, again, believing in God or not disbelieving in God is their personal wish. And science says that that's a completely different entity. Yeah, TV podichiti, yes. Even with gestures, you can tell. So, for example, you're telling when you're going out with your family, you're telling your son or something, or you're telling your wife, bring the key. So if they bring the house key, then how will you feel? So, when you're going out, it means that bringing the key means it is the car key that you're talking about or a bike you're talking about. So you know that and they understand that. So this is what we call as an abstract thinking, basically. So completely different. So you should not try to confuse only with proverbs. Anyways, so the judgment, logic, abstract thinking, all these things are basically coming from the dominant hemisphere only. And of course, you have the naming principles also. Naming is also coming from the your dominant hemisphere only. And what are the things that come from the non-dominant hemisphere? Basically, your creative skills, your new thinking, your fresh thinking, creative skills are the things that are coming from the non-dominant hemisphere. And probably your three-dimensional skills. For example, you want to construct something. You want to do something new. You want to construct innovatively. So you want to push something and your puzzles, you fit the puzzles into pieces. So this is something kind of a constructional thinking. So that's why I told you that puzzle is not a right word. Abstract thinking is different. So puzzle is something different. So thinking and telling is different. And again, constructing a puzzle and putting everything into pieces is again going to come from the right hemisphere only. It's a three-dimensional skill. And even dressing is basically a three-dimensional skill, example of a three-dimensional skill, which means even in your dark room, you can do the dressing, not a problem. Then everyone has different types of fantasy. I don't know what fantasy you have, but fantasy is basically a right-sided function. And you have philosophy. You know that you tell no, like, okay, beggar is there, okay, if you feel pity for them. Or if rich man is there, you feel like, okay, our country is sometimes, like this kind of irrational things are basically coming from the right side hemisphere only. When you see a rich man, you get angry without any reason. When you see a poor man, you get pity without any reason. You don't know whether their background is there or not. So fine, anyway. So these kind of things are basically very prominent in humans. So just based on the appearance, you get that philosophy. So that first point of non-dominant is actually creative thinking. So creative, three-dimensional skills, fantasy, philosophy, even music. Music is actually coming from the non-dominant. So I can tell verbal memory. So verbal memory means speech-related memory is actually a function of a dominant hemisphere, and non-verbal memory. You remember something by seeing it. You know how Taj Mahal looks like. So that's an example of a non-verbal memory. So you cannot describe, you need not describe it, but still if somebody shows you a photo, you immediately pick up that. So that's photogenic faces, photogenic memory. So that is also a type of a non-verbal memory only. All these things are functions of a non-dominant. And music is basically coming from the non-dominant hemisphere only. So there are so many things are there. And music itself, there are two things. You can split into tone and you can split into the charanam, and also each and everything has different like hemispheres that are storing them. So it's like, for example, evolutionary scientists believe that this kind of splitting of function is important for normal functioning, otherwise the brain itself will get confused. So that's why they are doing some individualized functions. So this is the basic concept of dominance, which is very important to understand. Rather, it is nothing to do with something called handedness. It has nothing to do with handedness. So it's all about dominance. So now we know that aphasia. What do you mean by aphasia? Anyone can define aphasia? Aphasia means problem of speech and language. Of course, yes. But it is not related to your motor power. Again, similar to what we saw for apraxia. Apraxia, we told like it's unrelated to motor power. It can be less or it can be normal, doesn't matter. But my inability to do a motor activity is apraxia. We know that. Similarly, aphasia, same kind of definition you can tell. My problem in my speech and language, but that is unrelated to my motor power of the muscles that are articulating in the speech. If I'm having problem in the subcortical regions that are involved in articulation of my speech, that will be dysarthria. If I'm having some cortical problem, remember cortical problem, but that is involved in my processing of speech. For example, involved in initiation of speech and language or language promoting centers in the brain, if that is having the problem and this is unrelated to the motor power, that is what we refer to as aphasia, which means aphasia is definitely a problem of the cortex. See, now Shubham is telling again normal motor sensory cerebellar. Absolutely not. You think the patients will be having normal motor sensory cerebellar all the time? So patient can have a Broca's aphasia. Along with that, you will have a facial nerve palsy. You will have a dysarthria and aphasia together. It is not a rule that the patient should have a normal motor activity. Patient may have an abnormal motor activity also. But what I'm trying to tell is that aphasia is unrelated to that motor power. Leave that motor power. Don't confuse that motor power. This is something else, which you're going to identify in a very different way. So definitely aphasia must be a cortical problem. So aphasia there are 2-3 things which you can derive. If it's a cortical problem, it can happen only in large vessel disorders, which means small vessel disorders, and subcortical problems will not result in aphasia. So which means I can boldly write that it cannot happen due to subcortical lesions. Definitely it is not subcortical. It cannot happen in subcortical lesions. It can happen only in cortical lesions, and it can happen only in a patient who is having a large vessel stroke. It cannot happen in patients who are having a small vessel or a subcortical stroke. These are the 2 important points that you need to know. And it's a problem of speech and language. So before going into the details of aphasia, let us see the, like the motor circuit where you get the aphasia. Motor circuit that is important in the development of aphasia. 1 second. Okay. So, I mean, Devi Krishna is asking difference between dysarthria and aphasia. I mean, at the end of the lecture, you'll understand. So till that, just stay tuned. So now, for producing a speech and language, you know that you need 2 important areas. One is called the Wernicke's area. And you have a Broca's area. Producing speech, you need definitely these 2 areas. We know that. So Wernicke's area basically is called as sensory speech area. And Broca's area is also referred to as something called a motor speech area. Nilash is asking, motor cortex lesion will result in dysarthria. Yes, of course, they will result in dysarthria only. They will not result in aphasia. Aphasia means you need to produce lesions in typical language promoting centers like Broca's area or Wernicke's. Then only you will get aphasia. Otherwise, you will get dysarthria only. So Wernicke's area, fine. So what is Wernicke's area? Basically, you can understand Wernicke's area like sort of a dictionary. That's how you understand. So it's not like important for word finding, but it's sort of a dictionary that processes what the patients are, what others are speaking, which means you're going to get an input here. And Wernicke's processes what is being spoken. And based on that, it gives a response to the Broca's. And Broca's is going to give the output in the form of a speech, motor speech area. And one common question that everyone asks me is that Wernicke's area is present only on the left and Broca's area is present only on the right or not. Yes, of course, I will tell Wernicke's is present only on the left, Broca's is present only on the right. The moment I tell this sentence, every student starts asking me one more question that, sir, then we studied that in anatomy that brain is bilaterally symmetrical. So a similar area should be present on the right side, of course. So then why there is no Wernicke's or no Broca's area on the right side? It's not like that. For example, if the area that you take as Wernicke's and if the area you take as Broca's, and if you extrapolate on the right side, there is a similar area that is present on the right side also, in the same area as that you have Wernicke's and Broca's. On the right side also you have it. But that will not be called as Wernicke's or Broca's areas because they are not involved in language promotion or speech promoting activity, which means the function of those areas, that similar areas that's present on the right side, we really don't know what the real function is. And that's why we don't really call it as a Wernicke's area or Broca's area. Point number one, that's very, very important, which means by our understanding, Wernicke's and Broca's areas are present only on the left side, not on the right side. Clear? So if you, only in the dominant hemisphere, because that is the one that is functioning. That's why we name that functioning areas as Wernicke's and Broca's. Non-functioning areas, similar areas on the right side, we won't be calling it as a Wernicke's and Broca's area. In any cut section of the brain, if you see, they will be showing the dominant hemisphere only. So the brain will be looking like this only. So this is the brain that they'll be showing, where Wernicke, Broca's, Wernicke's, everything they'll be showing like this. Why? Because they wanted to show the Wernicke's and Broca's only on the dominant hemisphere. They won't show it on the non-dominant hemisphere. No textbook will show the non-dominant hemisphere. You take and see today. And they cannot tell Broca's and Wernicke's in that particular side. That's why they don't show that, which means it's present only on the left side, which means these named areas are only named for functioning centers. So it's present on the left side, which means aphasia can also be there only if it's involving the left side. Only left side lesions can cause aphasia. Right side lesions are not possibly going to cause aphasia. Very rarely they can cause aphasia called as crossed aphasia, which we'll be discussing later on. But usually right side lesions will not cause aphasia. Only the left sided lesions are going to cause aphasia in the first place. All right. So what about that? What about Wernicke's? So for example, this has to be understood a little practically. Yes, Shubham already checked in the book. It's the dominant side or non-dominant side? What they have given? Only in dominant, no? Must be. Yes. So let us start with our basic understanding that I'm going to ask, what is this? So you had answered. I mean, it's your turn. What is this? So let us see in a practical way. What is this? Yeah, everyone is telling Apple Pencil, iPencil. Okay, whatever may be the case. Stylus, Apple Pen. So you know what is it? For telling you the answer, you have typed now. So this is even more a better scenario. I mean, you think that language is only speaking. No, language is a way of expression anyway. Even typing and sending like this is also a type of language only, which means you're able to communicate. Anything that is way of communication is actually a language only. So this is even more a better way to explain this. So you have understood, first of all. So what is this? So you understood. So the three words I asked, what is this? So you understood my context of asking, what is this also? Because I've showed something and I've asked, what is this? Which means that understanding the context of what I'm asking and understanding the three words, what is this, and analyzing them and processing them is the function of the Wernicke's area. Which means in the same context, I'm not showing anything. And now, for example, Shubham has said something else. For example, let us take Shubham's example. He has answered something else. And I've told, hey, what's this, man? So remember, the same three words I've added there. What is this there also? But the context I'm telling is completely different. My tone of voice is different. My way of telling what's this is different. So in that, he will be taking it as an insult probably. Hey, what's this? So you will not tell it's an Apple Pencil at that point. So your response will be completely different. You will be thinking like, okay, where I went wrong. So that's the idea of the entire Wernicke's theory. It's like probably a dictionary of the context of speech and all these things, what you are getting trained from our childhood through our environmental influences. So that's the basis of Wernicke's. Process the speech. It's the one that is helpful in comprehension. So I can write that Wernicke's area is the one that comprehends what others are telling and is going to analyze what others are telling. So the most important function of the Wernicke's area is going to be comprehension. And the moment I tell what is this, you will not be able to tell if you are having if you're having your eyes closed. If you're having your eyes closed, and if I show this and ask what is this, you'll not be able to tell, of course, because that really tells even your Wernicke's area is processing what is that. The three words that what is that, and even if it processes in the right context that what is this, that three words, unless and until you have influence from other areas that are remembering this. For example, you need your hospital cortex to see this. You need your other areas of your memory, I mean temporal lobe, to activate, isn't it? That this is a Apple Pencil and you have seen that. So which means only Wernicke's area can't produce a proper language. You need some association areas also. You need a lot of association areas. So for that matters, the association area that is associated with Wernicke's is what we refer to as something called a sensory speech association area. So of course, Wernicke's interacts with the sensory speech association area also. And after that only it will give information to the Broca's, which means it has to communicate with the other higher center. So this can be regarded as a higher center to Wernicke. Wernicke is like a basic center, but it has to interact with the higher center. And the higher centers are also involved in comprehensive purposes only, comprehension related purpose only. Then, of course, even if the Wernicke gives the information to Broca's, Broca's still communicates with the higher centers with its own association areas. And this is really, really important for a lot of reasons. Many, many reasons are there, but let us understand one simple reason. Motor speech association area. For example, if I show a photo, and some people will be able to identify him for sure. Let's see what you reply. You know what's going to happen. Stay tuned, but let's see. No pic. Yes, now the picture came. Who's this? Hey, he's a big doctor, man. I mean, he's not only a doctor, he's a plumber, he's a carpenter, he's a doctor, he's a staff nurse. He's a all-rounder basically. Yeah, basically. So you know who's this? So yeah, firefighter. I think last NP has seen him as a firefighter, I think, and Shubham last has seen as a astronaut, and Nilash is last seen as a massive. And Vijay Balaji is asking whether it's Gaitan or not. Oh my God. Gaitana. Okay. See the response. See, as you see so many people, what they have really responded. So they have responded with just a laughing smiley. So which means Wernicke told very clearly, it is basically Johnny Sins. So ideally, Broca, if Wernicke has told it's Johnny Sins, Broca should have told it's Johnny Sins directly. But Broca didn't tell Johnny Sins, which means it interacted with the higher centers, and your past association with Johnny Sins has come, and everyone had different past experiences, depending on whether it's a policeman or astronaut or what kind of scenario you last seen him. And you have told, and the association area has told that this is the best way to express yourself. And Broca has corrected itself, and it has to out or astronaut. Many people didn't comment him as Johnny Sins. That's the beauty of the association centers, because association centers are important in that particular perspective as well. So it's as simple as that. So you need association areas, which means association areas are basically not for comprehension. It's for word output, fluency and output. Your way you express yourself, the way you tell yourself. So this is going to be the importance of this motor association area. And whoever girls are here, I don't know about this thing. Please don't blame me for showing his photo. Don't tell that he teaches something else apart from medicine. No, just for fun, I showed that photo. And I sincerely apologize to people if I have hurt them in any way. Okay. Sorry for it. Anyways, so fluency and word output is there. So that is what the motor speech association, motor Broca's area and the motor speech association area is going to do in the first place. So which means it's very clear that you need all these areas. It's not only about you need some specific areas. You need all these areas to work synchronously to have a good fluency and output. Why, sir? Who is he? No, that's why I told you. He's like an all-rounder. Abhiram is asking who is he. So please don't search his name in Google, or please don't go and see who he is. He's a very good all-rounder. He knows. Yes, it's better not to know. That's what Karthik is telling. Better not to know. But he's an all-rounder. He's one of the iconic person I have. He has the biggest energy than anyone in this universe. Okay. So let us see what are the different kinds of aphasia. Like, for example, you have comprehension, you have repetition. So these are the ways to assess an aphasia. You're going to see the repetition, and I'm going to see the fluency and word output. Before that, I can tell the fluency, comprehension, fluency, and word output. Then I can go for the repetition. Then I can tell naming in this perspective. Then I can talk about reading, then writing, then finally I can tell where is the lesion also, of course, where is the lesion as well. So aphasia can be learned in much detail because everything is a question in this. So we're going to different types of aphasia. For example, Broca, Wernicke's, your accession area involvement, so many things are there. But one more important thing to tell is, repeat. I mean, in the sense like you are going to repeat what I'm telling. You have to repeat Kikuchi-Fujimoto disease. You're going to repeat with me. Kikuchi-Fujimoto disease. Okay, Riju is the first one to comment. Kikuchi, you answered Fujimoto also. Okay, Alex has replied Kikuchi-Fujimoto disease. Ishan has told Kikuchi-Fujimoto. Okay, fine. Vijay also has answered Kikuchi-Fujimoto. Okay, how many of you don't know? Honestly, you tell, how many of you don't know what is Kikuchi-Fujimoto? I mean, honestly, agree. How many of you don't know? Hari don't know. Pranvi don't know. Monica don't know. Yeah, so many people don't know what is Kikuchi-Fujimoto. Then why did you reply? Then why did you reply? You're thinking like, what stupid is he asked me to tell? Yeah, that's what you're asking. You asked for it. That's why I replied. So cool. That's what it is. So which means for repetition, you don't use your higher centers, which means for repeating, you just need Wernicke's, communicating fasciculus, and Broca's. That's all. You did not use your association areas, isn't it? You didn't use your higher center at all. So which means to repeat something, you don't need higher centers. That's the basic idea. And all you need is Wernicke's, the communicating bundle, and the Broca's areas. Just you released it outside. That's all. You didn't think of anything else because I asked you to repeat. As simple as that. So now this communicating fibers becomes really, really important in this setting. This is what we refer to as something called a arcuate fasciculus that communicates with the Wernicke's and the Broca's area. That's arcuate fasciculus, to be precise. And that's why, remember, for repetition, you don't need higher centers. You just need the basic centers. That is Wernicke's, arcuate fasciculus, and the Broca's is enough to do a repetition. If there is any problem there, you will not have repetition. Otherwise, you will have repetition intact. And at the same time, remember, naming is an extremely complex process if you want to ask about naming, which means it's not easy to name unless and until you have all the centers. I told you in the example of this pen, I told you very clearly, I showed you an example of a Johnny Sins also, where most of the people answered differently. So which means you really believe that naming doesn't need only one thing. Naming needs multiple other communication, which means all the areas are equally important for naming something. Naming is an extremely complex process from the evolutionary perspective. So with that, let us start our understanding. First, it's going to be Wernicke's aphasia. As far as Wernicke's aphasia is concerned, of course, you are going to lose the comprehension. That's the most important thing, which means if I ask what is this, and this is processed as how is this, and you will be answering good. That's what you will be answering. So which means what I asked is what is this, and your answer final reply is good, and which means it looks as if you are a mental. So of course you lose comprehension. There's no doubt about that. Whenever you have Wernicke's aphasia, and more importantly, one more important thing is this Wernicke's area You can imagine, it's not a correct thing. Please take my word. It's not a very correct thing. But to imagine that Wernicke's area is going to keep the Broca's area under inhibition unless and until it's getting stimulated by Wernicke's. You can understand in that way. I mean, how can you get it in the practical ways? You don't speak unless and until it is really needed, isn't it? So you don't keep blabbering all the time, even though some people will have a poor inhibition of Broca's. But most of the times, you don't really speak unnecessarily unless and until something is asked. So you can remember, like, Wernicke's is keeping the Broca's under inhibition. So once the Wernicke's area is gone, your Broca's area will be released and they will be keeping on speaking. So the fluency and word output will be basically increased. And as far as the repetition is concerned, we know that Wernicke, arcuate fasciculus and Broca is important for doing a good repetition. So since Wernicke's is lost, repetition will be lost. You will not get repetition. And remember, naming is a complex process. I told you it will be lost in any kind of aphasia, doesn't matter. And remember, the Wernicke's and the associated higher center is important for reading, in the sense like this is also called as sensory speech area, or this circuit, this accession area and Wernicke's area is important for reception. So that's also called as a receptive area, which means they receive the information. And this Broca's area and its motor speech accession area is also important for expression. So that's why this Broca's area and motor speech accession area is also thought to be expressive. They are the ones that express what you really want to think. It's not hyperactivity. That's why I told you, don't take it in a literal sense. It's not hyperactivity. Generally, because to help you understand that in Wernicke's, the fluency and word output will be higher. So I told that particular analogy. That is not basically a correct thing that happens. There are a lot of underlying neurological principles that works there. So fluency and word output will be more in the setting of Wernicke's. I want to tell that point only. That's why you should not overemphasize on that. So then you have something called reading. So remember, for reading, you need to first take in the thing. So which means reading is a more of kind of a reception. Writing is more of an expression. So if you have Wernicke's issue, you'll have a problem in reading, but they can have problem in writing. But please understand, you can ask without comprehension how they can write something. They will write, again, that will not make any sense. Poor comprehension only. So whatever they write, they will, maybe they might be expressing something, but that doesn't make any sense to you. Similarly, comprehension is lost means even if they speak a lot, here, you should be very clear that it will not make any sense. There will be absolutely no comprehension, and the patient, it will not really make any sense at all in that. It will be absolutely poor comprehension. So which means it's nonsensical speech. They'll be completely speaking nonsense only. They'll be speaking something else which you can't understand. Even they can't understand what they're speaking. That's the idea. And that's what we call it as a jargon. And many times they form new words. And that's what we refer to as something called a neologism, new word formation, jargon speech, neologism. And as far as the lesion is concerned, yeah, I mean, INRINR 98 is telling my speech in Viva. Okay. Good. Even my speech in Viva also most of the times used to be like that. Especially I remember my forensic medicine Viva, which is the best one I ever had in my life. Okay, lesion. Lesion typically will be in the postero. I'll explain you that. Lesion will be typically in the postero-superior temporal lobe. That is where Wernicke's area is located, postero-superior temporal lobe. And usually the artery that is involved is the middle cerebral artery, inferior branch. All these things will make sense in some time. Don't worry about that. I mean, that's why I've not drawn the image yet. So that's why you will not be able to tell right now. So most of this will be visible in some time. First, right now, MC of the inferior branch. That's where you will get the Wernicke's aphasia. Then you have Broca's aphasia. For example, let me come back to that. So Broca's aphasia means the problem is on this circuit, which means the expressive circuit. That is where the problem is. The expression will be a problem. How can they be fluent if the repetition is lost? Repetition means if I tell you repeat Kikuchi-Fujimoto disease and you are repeating this. Are you able to see what I'm repeating? You're able to repeat, right? You're able to see, or you're not able to see? Okay, now I'll see. Okay. So now let us assume who asked this question. Harshad is asked like, how can they repeat? So let us assume Harshad is asking me to repeat Kikuchi-Fujimoto disease. I am repeating this. I mean, simply just for understanding, I'm telling. What is that? Nobody can understand. Even I don't know what I repeated. So that is Wernicke's. Yes. So do you tell this is repetition or this is not repetition? This is not repetition. This is not what I was asked to repeat. So absolutely fine. So I think now you can understand. So fine. So Broca's area is there. So I mean Broca's aphasia is there. As far as Broca's aphasia is concerned, so now comprehension will be intact because my other side is fine. No issues. My Wernicke's area and other association areas are working perfectly all right. As far as my fluency is concerned, it will be severely impaired, which means Broca is important for the output. So that will be lost. So as far as my repetition is concerned, it will be not perfect. It will be very difficult to do a repetition because the person can understand what he wants to tell, but he will not be able to, he will struggle a lot to tell. So which means that struggle can be seen in their face actually, how much they will struggle to talk something. That's Broca's basically. And as far as naming is concerned, it will be lost because, I mean, in the sense like it will be very severely impaired. That's what I'm trying, because naming needs all the areas to work perfectly and synchronously. Reading, yes, possible, which means reading is a receptive process. They can read and understand what it is given in the textbook, but writing will be extremely poor. They'll be having a serious difficult writing because it's a sort of an expression. So where is the Broca's aphasia? I mean, there's the problem in the Broca's aphasia? You should typically write in the inferior frontal gyrus. This has been a multiple times asked question in the past, and it can be asked in the future as well. So that is inferior frontal gyrus. And typical arterial location is, it's going to be in the MCA territory, superior branch. Superior branch of the MCA is the one that's going to be involved if you are going to get a Broca's aphasia. Let us discuss about that in some time. And more importantly, one more important feature of Broca's area is that syntax will be lost. It's not only the fluency that is decreasing, the syntax, that the context of speech, that the grammar. So you can remember in any way. Syntax is like a context, grammar, or a best example of a syntax is the beauty of the language, which means when you go and propose a girl, you don't go straight away and tell like, you don't go in front and tell, I love you. Like she will slap you, man. So, and that's not the way to express yourself. And what do? You know, like you first plan a lot of stuff. You catch your friend and you catch friend's friend, then you get the number and then you message hi. So you do a lot of things. Then once you get the time to propose, so what do you tell? So indirectly you tell, isn't it? You don't tell. For example, one of the best pickup lines, you know, it's been there for a long time. Whenever I see you, I get Mobits too. So what is Mobits too? Basically, you get a skipped beat in between. So indirectly you can tell, whenever I see you, my heart skips a beat. Whenever I see you, I get Mobits too. In between, my heartbeat gets a skip. So that's way of expression, right? So that's something like a syntax, the beauty of the language, in what way that you will express stuff. So that's going to take a huge hit in the setting of Broca's aphasia. The syntax will be lost. The context and the grammar and the beauty of the language will be completely lost here. The way of expression, all these things you learned over time. Fine. So then your association areas, for example, let us assume your association areas are taking a hit now. These areas are getting lost. So as far as the association areas are concerned, whenever the sensory speech association areas is damaged, then that's called a transcortical sensory aphasia. That's called a transcortical sensory aphasia, which means my association area that communicates the Wernicke's area is lost. So in this again, because it's on the Wernicke's side, it's going to be having a poor comprehension, and at the same time, what about the fluency and word output? Remember, I told you only Wernicke's is going to inhibit the Broca's, not the association area, which means, to be honest, there won't be any problem as far as the fluency and word output is concerned. It will be completely normal. And even if it is normal, the comprehension will be lost, and whatever they speak will be an absolute nonsense. Clear? So they will not make any sense at all. But the fluency and word output will not be too much like Wernicke's. It will be normal only here. You can understand that. Then what about the repetition? Repetition will be intact. This is a very, very important feature of a transcortical aphasia, because many students might ask, how can a person repeat if they don't understand what I'm trying to tell? The same question can come here. But remember here, the person will not repeat basically, but I mean, the sense repeat in the sense will not repeat what you asked to repeat, but they will tend to repeat whatever you say. Echolalia will be there. That's a sign of repetition here, which means whatever you speak, you will tell the same thing. So that means repetition is intact only. So that's a sign of repetition only. So that is how you find out that these guys have repetition intact, even though they don't have comprehension. Then what about naming? Naming is a complex process. I told it will be lost in all the types of aphasia. Then you have reading, which cannot be done because reading is a reception. Wernicke's and oscillation centers are important. Writing can be done. And once again, whatever thing they write, it will be not having any sense. Poor comprehension. Clear? So where is the, transcortical sensory aphasia location? Repetition and echolalia. The reason why echolalia is not in Wernicke is because the fluency in word output is increased seriously. Fluency in word output is increased seriously. That is one reason why it is there, which means they will be speaking continuously. They may not be repeating what you wanted to say, but they'll be repeating, they'll be talking something else continuously. So this is the reason that is going to completely affect the repetition, and they won't even listen to what you say. Here, at least they seem listening what you say because they are confused. They don't know what they wanted to say, and at the same time it's something different. So both are completely different. Repetition beyond relevance is echolalia, correct only. Then you have writing which will be intact and but still it will not make any sense. And at the same time, where is the problem in the setting of transcortical sensory aphasia? So usually it will be located in the posterior and inferior zone to that of the Wernicke's area. Posterior inferior to Wernicke's area, that is where it will be located. Usually the the arterial territory that it is going to get affected in transcortical sensory aphasia is the PCA territory. Very important point. It is the posterior cerebral artery territory, or it could be happening in the watershed territory. Watershed between MC and PCA. MCA, PCA, watershed in fact also can cause this type of transcortical sensory aphasia. Then the next one, which will be much easier for you to understand, that is transcortical motor. So I'm not going to show now. You are going to tell what are the features, because it's the higher area that is on the other side, in the Broca's side. So which means the comprehension will be there, repetition, fluency will be seriously impaired because it's an expressive area, and the repetition will be still there because it's a transcortical area. Higher center will not affect the repetition, and of course naming will not be there. Reading is possible, but writing is seriously impaired. And what is going to be the territory, which area it is present? It is actually antero-superior, anterior and superior to Broca's area. This is the usual area that is affected in the setting of a transcortical motor aphasia. And remember, most importantly, it is present in the ACA territory. Clear? ACA territory. That is, this is MCA, PCA watershed. Posterior cerebral artery and middle cerebral artery watershed area. That is where it will be located. I'll show you in some time. So then antero superior to Broca's area means it will be located in the basically in the anterior cerebral artery territory. Remember, these are the only two aphasias that are located in different territory. Most of the other aphasias will be located in the MCA territory only. So most of the aphasias, whatever I'm going to talk, is going to be located in the MCA territory only. Only transcortical aphasias will be located in the other territories like PC and ACA territories, like sensory PCA territory predominantly, and motor it will be located in the ACA territory. Then point number 5, and the fifth thing is the global aphasia, which is very easy to understand. As far as global is concerned, nothing will be intact, fluency will be decreased, comprehension will be lost, repetition will not be there, naming will not be there, reading, writing, nothing will be there. It's easy to find out the global aphasia. And very commonly, it will be a very proximal MCA territory, in fact, which means it will not be specific at the superior division or inferior division. Even before that, the MCA will be affected. So it will be usually a proximal MCA territory, in fact. And number 6, you have something called a conduction aphasia. So in conduction aphasia, the problem will be in the arcuate fasciculus. Arcuate fasciculus will be damaged. This is the problem in conduction aphasia, which means not all the fibers will be damaged. Still some fibers will be intact. But when they're taking a genu against the, not genu, when they're taking a curve against the angular gyrus, that part is very commonly affected in conduction aphasia. Repetition is seen, yes. Repetition is present in motor conduction aphasia, but echolalia may not be the case. They can actually repeat because they understand what you are telling. They will not appear confused. Only if you are confused, you will be telling whatever the other person is telling. that's the important psychiatric principle also. If you're not confused, if your comprehension is good, you will not be really doing an echolele. You will be able to tell what they are asking you to repeat. As far as the conduction aphasia is concerned, in conduction aphasia, the comprehension is intact. The fluency is also okay, but even though the fluency can be normal or decreased, because you have to communicate. Wernicke's has to communicate to the Broca's that communication is lost, means fluency can be normal or as to a slight extent can be decreased. And then if you take about the repetition will be seriously impaired, because this arcuate fascicle is very important for conducting the repeated words from Wernicke's to Broca's. So that will be taking a huge hit here. And at the same time, what about your naming? Naming will be seriously impaired, because you need everything for naming. And reading can still be intact, because Wernicke's is okay. Writing may be normal or can have a mild impairment possible. And the lesion that is usually seen is in the supramarginal gyrus. I'll show you where is the supramarginal gyrus. This is where the lesion will be usually. And number 7, you have something called an anomic aphasia. This is a very peculiar type of aphasia, anomic aphasia, where everything will be intact. So comprehension will be there, fluency will be normal, repetition will be intact, reading will be normal, writing will be normal, only naming will be impaired. So only thing that is affected in anomic aphasia is naming, and the usual lesion localization is angular gyrus. Angular gyrus. Remember, again, the vascular territory that is commonly affected is MCI territory, and vascular territory that is often affected is the MCI territory. How reading is okay? Wernicke's has to conduct to Broca. And like for reading, why you need Wernicke's to conduct to Broca? For reading, just this comprehensive center is more than enough, right? So why you need Broca for reading? Broca is only for output. It's a motor speech area. For reception, for understanding things, you just need this and this, right? So why you need arcuate fasciculus and Broca's area for reading? I don't think so. I mean, this is Alekia's doubt. So that's why I want to answer again. Writing area, writing area is basically located in the parietal lobe only. Okay. Fluency is normal or decreased. Why fluency is decreased mildly in conduction aphasia is because, you need to communicate with the Broca's, isn't it? So when you cannot communicate sufficiently with the Broca's, definitely fluency will be decreased. So whatever is coming to the Wernicke's, that has to go properly to the Broca's. If you cannot send the signal properly to the Broca's cannot be able to get the input from the Wernicke's, so the fluency will be decreased. Definitely decreased only to some extent. Lesion in anomic aphasia, it's in the angular gyrus. I'll show you, man. This might look very difficult, but once we draw the image, it becomes very simple. It's in the angular gyrus. That is where you get the anomic aphasia. So clear? So this table is really important. Even though I tried to simplify it as much as possible, so it will give a lot of sense once you go and read back in the, like in your home, it will create a lot of difference. So you'll be understanding much better. Okay. If you're okay with that, let us move to the next thing. You want to move my head. So wait, I'll remove my head first. For that. I think now you'll be able to see properly. Okay, fine. So no need of anything else. Let us go back to the discussion. So otherwise it will be difficult. Clear? That's it. So we'll move to the next thing. So otherwise it will keep on popping out. So you have to clear the confusions yourself from now on. I've tried to simplify as much as possible. All right. So now we need to know what is the stroke localization. So now we know the different kind of words. We expanded what you mean by homonymous hemianopia. We expanded one more thing. What is that? That is agnosia. We expanded what you mean by apraxia. We also expanded what you mean by aphasia. But now it's time to localize the stroke in a much better way. So first, we are going to start with the anti-circulation stroke first. As far as the anti-circulation stroke is concerned, you can have lesion in the internal carotid artery. You can have lesion in the middle cerebral artery, anterocerebral artery, or you can have lesion in the middle cerebral artery. So this is where you can have the lesion. So we are talking about a large vessel stroke. Remember, you're not talking about a small vessel stroke. In this particular segment, we are talking about a large vessel stroke, the thrombotic or the embolic stroke. Because once you go to the small vessel stroke, this will not make any sense. So we're talking about a large vessel stroke. So ICA stroke, usually you will have a mixture of features of both MCA and ACA. And apart from that, one important finding is that will surely tell that it's an internal carotid artery stroke. What is that finding? What is that finding that will surely tell that the patient is having an internal carotid artery stroke? What is that particular finding? Have a mixture of MCA plus ACA territory stroke because it's basically mother of two arteries, that is ACA and MCA. So that's fine. So I'll tell you ACA and MCA later on. But one finding that will surely tell you that this patient is having a ICA territory stroke. One finding. No, I mean some people are answering painful orner. That's not the case because painful orner is a feature of ICA dissection, not a stroke. We're talking about a stroke here. So that is monocular blindness, ipsilateral blindness. So whenever you get a stroke that produces blindness, get a visual field defect like a homonymous hemianopia or a heteronymous hemianopia, then that's fine. So then it can be MC or ACA territory stroke, doesn't matter, or it can be happening in ICA territory stroke itself. But whenever you encounter this kind of monocular blindness on the same side, that is equal to, or you can call it as amaurosis fugax also, doesn't matter. But that blindness with a stroke, one eye, is equal to ICA territory stroke. This is a very, very important question in exam. So if they give you this, you can concretely localize ICA territory stroke. No other stroke in the brain will cause this kind of ipsilateral blindness kind of a picture. So why they produce ipsilateral blindness? Why they produce ipsilateral blindness in the first place? Yes, that is due to involvement of the ophthalmic artery. Because as far as you know, this IC has many divisions. IC has many segments. For example, internal carotid artery, if you take from here, it has many different segments. For example, you have something called a cervical segment. And then you have something called a petrous segment, of course. I think you would have heard about all these things in anatomy itself. You have something called a petrous segment. Then you have something called a cavernous segment, where the internal carotid artery passes through the cavernous sinus. You have cavernous segment. Then apart from the cavernous segment, you have something called a supraclinoid segment. Supraclinoid segment. Then you have other divisions, that is ophthalmic artery, that comes directly from the ICA, and ophthalmic artery is the one that gives rise to the central retinal artery. And this is our artery of concern because in ICA territory stroke, the ophthalmic artery involvement is the one that is going to cause this kind of blindness, that is amaurosis fugax, whatever you talk about, producing a central retinal artery occlusion kind of a picture. And finally, it gives rise to something called a posterior communicating artery. Usually you don't have much branches from the cervical segment, but you have a lot of branches from the Peter segment, but none of them are basically named branches are there. But you have some branches from the cavernous segment. So from the cavernous segment, usually your supply will be to the posterior pituitary through an artery called a meningo-hypophyseal artery. So that is the one that is going to supply the posterior pituitary, to be precise. And supraclinoid segment gives rise to basically 3 branches. If you want to know what are the 3 branches that the supraclinoid segment is going to give, one is the ophthalmic artery, of course, which means that's the next one. So you can remember that is going to come from the ophthalmic artery. And of course, it's going to be the anterior choroidal artery. And third one is the posterior communicating artery. So which means I missed one thing. That is anterior choroidal artery I missed, I think, here. So before the posterior communicating, there should be anterior choroidal. Anterior choroidal. And finally, I can write posterior communicating artery here. We know where the posterior communicating artery is going to be. Okay. So which means from the supraclinoid segment only, you are going to get these 3 branches. I don't know why it went. Sorry, 1 second. From the supraclinoid segment only, you are going to get these 3 branches. That is ophthalmic artery, anterior choroidal artery, and you are going to get the posterior communicating artery as well. So ophthalmic artery, we know that is the one that's going to give rise to that particular type of central retinal artery, which is going to supply the entire ipsilateral eyes retina. And apart from that, we have the anterior choroidal artery. So what is the supply of the anterior choroidal artery, which is, what is the most important feature of anterior choroidal artery with respect to a stroke? No, anterior choroidal artery does not give rise to the recurrent artery of Hubner. It is the anterior cerebral artery that gives rise to the recurrent artery of Hubner. Yes, the most important point with regards to stroke is they supply the internal capsule. That's the most important, especially the posterior limb of the internal capsule, which we'll be studying in some time. I'm going to explain that. So let us delineate one by one. So posterior limb of the internal capsule is supplied by anterior choroidal artery. So that is why this is important to us. Apart from that, it has branches to the midbrain. It has branches to the lateral geniculate body of the thalamus. So it has branches to the optic tract. Certain part of the optic tract is also supplied by this anterior choroidal artery only. So that is not important for us. And we know the posterior communicating artery also. Posterior communicating artery is basically very important for our understanding because it's a very common site for aneurysm formation, isn't it? But it still supplies the thalamus, hypothalamus, optic chiasma, mammillary bodies. Many areas it can supply. But as far as our clinical neurology is concerned, it is a common site for aneurysms. And anterior choroidal artery is going to supply the internal capsule. That's the posterior limb of the internal capsule. Ophthalmic artery involvement is going to result in the development of a amaurosis fugax or ipsilateral blindness. So all these 3 branches are basically coming from the common branch called a supraclinoid segment. So these are the segments and branches of the internal carotid artery. But whatever may be the case, internal carotid artery is ultimately going to be the mother of other 2 arteries, that is the anterior cerebral artery and the middle cerebral artery. So many times they can show mixed features of MC and ACA territory involvement. But more than that, whenever there is an ICA stroke, the most important thing that you get in these patients is this monocular blindness. That is a classical feature of an internal carotid artery stroke. Very, very important point. So that's going to be the exam question. Remaining whatever you want to know, I told you already. And ICA territory strokes are supposed to be extremely dangerous. My statement is true statement or false statement. In the sense they will result in severe weakness. ICA territory stroke must result in severe weakness. True statement or false statement? Actually, no. Actually, no. They don't result in that much of severe weakness. Why? I will tell you. For that, we need to go to the circle of Willis once again, because there is going to be substantial anastomosis in the brain. For example, when you go back to the circle of Willis and see there, because I've drawn in the subarachnoid hemorrhage, I think. Yeah. So here you can see, even if I block the ICA, level, So this one ICA, if it's gone also, so there's a lot of chance that the other vessels can be supplied through the other part. For example, this ICA can give rise to ACA and MCA, and of course through the posterior communicating artery and the anterior communicating arteries, they'll be able to supply the other side because the anastomosis is very good. Yes, so the anastomosis is going to become very great here. So depending on how much the anastomosis is there, depending on the level of ICA involvement also, the symptoms will vary, which means in proximal ICA occlusion, you might be expecting that the patient might be having severe symptoms, but actually no, even in a patient who's having 100% and a complete ICA occlusion, we have seen patient walking out of the hospital with a full power. I mean, not full power, maybe like with just 4+ or 4 power, and they don't lose completely. That is because of the anastomotic circulation, and they can well perfuse the other side of the brain also. Remember, the more distal you go, more is going to be the problem, which means the end arteries, when they are affected, they're going to cause a lot of serious trouble. That's something which is very important to understand as well. For example, if you talk about lenticulostriate branches, they're affecting the internal capsule, which is a very compressed bundle. At the same time, these are end arteries, lenticulostriate branches. You don't have any anastomosis. For example, if you affect the MCA, one of the cortical branches, you don't have any anastomosis at all. Very difficult to get anastomosis in that zone. So the more distal you go, beyond the circle of Willis, more is going to be the problem because that area cannot be salvaged by any other anastomotic circulation. The more proximal you get, especially like in cases of internal carotid artery infarction or occlusion, you might get a good anastomosis so that the blood supply may be good in the other areas. So then what about the ACA territory infarct? What are the features of ACA territory? Now I'm going to put on diagram before I leave you for a break. But before that, what is the ACA territory infarct? What are the features? People who know that already can tell. Of course, they're going to cause a stroke and they're going to cause weakness. So as far as ACA territory stroke is concerned, this weakness will be involving the legs. So anytime in exam, whenever they give legs as a prominent entity, you think about anterior cerebral artery related stroke. For example, if they give a hemiparesis, but if they tell legs are involved more than arms, so then that suggests usually a ACA territory stroke. And apart from that, if they tell something called a gait apraxia, a stroke that is causing a gait apraxia must be an ACA territory stroke. This is another clue. At the same time, if they give a paraplegia, so this also goes towards a stroke with a paraplegia. I'm not talking about spinal cord lesion also can produce paraplegia, but a stroke causing paraplegia usually will be due to a bilateral ACA. Usually will be due to a bilateral ACA infarction, clear bilateral occlusion. And at the same time, if they give the word called incontinence, because there is an area on the medial side of the brain called as a paracentral lobule that is basically supplied by the anterior cerebral artery only. If that is damaged due to ACA infarction, you'll get incontinence. And if they give something called an abulia, abulia is basically like a poor thought process or a slowed down thought process. For example, if I want to drink this water, I immediately decide for or against it. But if I'm seeing this water bottle and thinking whether to drink or not for maybe for 15-20 minutes without making a decision, so that's one example of an abulia. It's a little bit worse form of apathy. And you have extreme form of abulia and apathy that is happening in schizophrenia, that is anhedonia, where you're not able to make any decisions at all, thought process completely. So this is abulia. So inability to make decisions quickly. Thought process itself is slowed down dramatically. That is because of prefrontal cortex involvement. And the patient may get symptoms of disinhibition because the prefrontal cortex is the one that makes decisions and makes social judgments. So disinhibition is a disinhibitive behavior, which means you don't want to do something, but still you decide to do something because you have the disinhibitory behavior. For example, one of the important areas of interest is the prefrontal cortex. If they ask you the seat of consciousness, so then you can talk about the reticular formation, which is present in the brainstem. In the central part of the brainstem, there is something called medial reticular formation that is going to be the seat of your consciousness. But if you ask about the seat of civilization or seat of your social behavior, you will tell one important area, that is the prefrontal cortex. It is the frontal zone of the prefrontal cortex. In fact, most differences between the animals and the humans actually is present in the prefrontal cortex only. Our prefrontal cortex will be extremely big, and that is important because we have a biggest social group in the among the entire animal kingdom. If you take, we are the ones, we are having the biggest social group, because no monkey creates a social group with a monkey in the Zimbabwe or other parts of the country. So we have the biggest social group by far. That is because of our hyper expanded prefrontal cortex, and that's the seat of social activity and all this stuff. So whenever you lose the prefrontal cortex, which is basically supplied by the antecerebellum to a great extent, you will lose that social behavior. So which means disinhibition also means it's antisocial behavior. Please remember, I'm not talking about anti-Indian behavior. I'm talking about antisocial behavior. And what do you mean by antisocial behavior? Anything that is not social is going to be antisocial. In the sense, for example, if I am sitting here and I wanted to pee, I go back and I pee in the screen, and I come back and sit here and I start writing again. So that's, in a way, it's correct. If a dog does that, you will agree to that. Probably if a monkey does that, you agree to that. If I do that, you don't agree to that, because I have not been taught in my community to do something like that. So I'm doing something against what I've been taught and against what everyone universally thinks that is wrong. So that's what we refer to as an antisocial behavior, which is antisocial behavior doesn't need to be only killing and murdering someone. It can be this kind of simple kind of behaviors also, where I'm speaking foul language in areas where I should not speak. If I'm speaking with my friend, I'm bitching about someone, in that time speaking about some bad word to my friend. Okay, it's my close friend, so that's acceptable according to us. But if I take a mic and go to the road and speak foul language about someone, police will arrest me, because that is actually causing verbal nuisance to someone. So that's an antisocial behavior. So number one. And even though politicians do that, we don't call it as an antisocial behavior, because we think it's a part and parcel of them, because they are basically antisocial. So we don't care. But if I do that, definitely police will arrest, and you believe it is a antisocial behavior. And that's what is going to happen. You're going to have personality change. Have you heard of anyone called Phineas Gage? Anyone knows who's this? I mean, no neurology classes will start without him, and no psychiatric classes start without him. Who's Phineas Gage? Riju is telling he knows Faraday cage. You're talking about Phineas Gage. Frontal lobe had a rod. Okay. Suddenly, because I was thinking about Johnny Sins when Ishan told frontal lobe as a rod, I thought something else. Okay. So Phineas Gage is the person who was hit with an iron rod. And he was a very landmark case in the world, because he was working in the railway construction site, and they used to blast the stones to produce this kind of ways for the railroad to be established. So when some accident happened, and there was a big iron rod that actually protruded through his cheekbone, that is the zygomatic bone, and went behind the orbit, and came out through the frontal area, from this area, and that rod actually went 30 meters behind him. So you can understand the impact of injury that he had. He's Phineas Gage, and that's the first landmark case, and showed the importance of the prefrontal cortex, because prefrontal cortex makes a very important connection with the limbic system. You know what limbic system is for? Limbic system is to make some emotions. That is limbic system. And there is a lot of white matter tract that communicates with the limbic system, and prefrontal cortex is actually established to inhibit the limbic system, basically. Because, for example, in front of someone, for example, if it's a live class or if it's a face-to-face class, I scold someone very badly, like, you are an idiot, man, you don't know anything. So if you scold someone in front of them, you'll feel like you have to cry. But suddenly you realize that there are so many people who's there around you, and you stop your tears. So why you stop your tears, even though limbic system is telling that that's an emotion that is originating from you, but somebody has insulted me, but you don't cry, or you go somewhere, you go to bathroom, or you tell like I'm going out, or you show it in a different way, like you get angry on me and you get out of the class. So that's the kind of that's the kind of thing that frontal lobe does, the prefrontal cortex does. It adapts you towards your society, and at the same time it creates a sort of an inhibition to certain activities which the society has taught not to do in public. So that's what we refer to as a disinhibitory behavior, which means it's not only about antisocial behavior and disinhibition. You are going to have a severe personality change, and that's the same thing that Phineas Gage also experienced. Phineas Gage also, after this frontal lobe has been, a chunk of the prefrontal cortex has been removed and his white matter that is communicating with the limbic system has been severed. He got a kind of a complete personality change, and his friends used to tell that it is a mad person after that, and he became extremely angry for small things, and he had a completely disinhibitory behavior, even though it happened in 1860, where the notes were not so clear about that particular case. But still, this is the first case that showed the importance of the prefrontal cortex during those days. And after this case only, they thought that if you cut the like connection with the frontal lobe and the limbic system, you can treat certain disorders like your schizophrenia or severe psychosis. You can treat those disorders. So what they wanted to do is, because frontal lobe is the prefrontal cortex is the thing that creates that sort of fantasies, and they wanted to show some emotions, and that is the one that creates all this problem in certain schizophrenic and psychotic patients. So they started doing a modern procedure. It's a modification of Phineas Gage's injury, where Phineas Gage's injury went through the zygoma and came behind the orbit and came out through the prefrontal cortex. But what happened in the setting of modern surgeries, they did something called orbital frontal fiber resection. You would have heard about that, isn't it? Frontal orbitotomy. That, like, they put an iron rod behind the orbit, and they used to sweep down the frontolimbic connection. They used to cut that connections. So that's one of the modern surgeries that was actually thought after this Phineas Gage's injury only. We thought that the severing the connection in the limbic system may be helpful in treating some severe psychotic disorders. I think everyone would have seen Shutter Island movie, I think. How many of you have watched the Shutter Island movie? Basically. Yes, everyone would have seen the Shutter Island movie, where they do something called orbital lobotomy, isn't it? That's a modernized lobotomy. And that's how they take Leonardo DiCaprio at the end towards that particular kind of surgery only. There, yeah, it was too intense. You left it midway. Yeah, in the end, Leonardo DiCaprio willingly, voluntarily goes for that surgery because he don't want to live with the guilt of, murdering their wife, his own wife. So he purposely want to forget all those things. So he goes for orbital lobotomy. Everyone would have seen that movie. That's a very good movie, in fact. So these are the movies that are basically taken with the help of this prefrontal cortex involvement only. Prefrontal cortex is so important in our life. That's the one that keeps you absolutely social. And don't ask me, sir, if I'm loving other community girl, my community, opposes all those things. Is it antisocial behavior? No. I'm talking about what all humans generally believe it is antisocial. It's not like antisocial only for you or your community. We're talking about entire human beings, because these kind of questions also might come in the midway. Then apart from that, they are going to get something called release reflexes. Release reflexes. So what do you mean by release reflexes? Anyone? There are many reflexes that are suppressed by the prefrontal cortex. What are the examples of release reflex? You have something called grasp reflex. You have a palmar grasp and a plantar grasp. You have sucking reflex. You have rooting reflex. Then you have the glabellar tap. So many release reflexes are there. Reflexes are there that are basically suppressed. These are primitive childhood reflexes that are basically suppressed by the frontal lobe, especially the prefrontal cortex. And those, they can get back if you have a prefrontal cortex damage or if you have a ACA territory, in fact. You have to basically suppress these reflexes. For example, you cannot go in the bus, whenever there is a auntie next by. So in the bus you're going and suddenly your palm is touching that auntie and you're suddenly grabbing that auntie. What will happen? The whole bus will trash you. You cannot tell auntie, I'm having a prefrontal cortex problem, so that's why I'm grasping whatever I'm seeing. And that's not possible, isn't it? Even that is fine. Sucking is even more bad. That's not correct. So all these things, and sucking should be appropriate, and it should be correct, and it should be on the right purpose. And unlike baby, you should not suck everything, whatever that comes into your mouth. So that's also very bad. So basically, these are what we refer to as release reflexes. And yes, these are what we refer to as release reflexes, and they can come back whenever you have a prefrontal cortex damage or you're going to have a ACA territory, in fact. Cool. Riju is telling us, I won't hug her because Moro won't reappear. Okay. You are very bad, man. You are the baddest I've ever seen. I want to see you in front one day. Let me see. Okay. So you have a AC territory infarction. So this is what we call as AC territory infarction. Hope you understand AC territory infarction. These are the most important points that you should think about whenever you think about a AC territory infarction. Then what about the MCA large vessel infarct? MCA territory infarction. As far as MCA territory is concerned, once again you will get the weakness in a distribution, and predominantly your weakness will be distributed in the arms and the face. So this is the most important characteristic feature of an MCA territory infarct. So which means you will be having hemiparesis, of course, and you will be, but this hemiparesis basically will be involving more of arm and face more than the legs. That's really, really important. And at the same time, you can get only arm and face weakness alone. That is called a faciobrachial monoplegia. So that's a different name. So anything that is concerned with arm and face predominantly, you can think about an MCA territory infarct. And number two, second thing is like you can get aphasias, and which means the characteristic feature of what we saw in anterior circulation stroke, that is hemiparesis and aphasia, are very characteristic in a MCA territory infarct only. So fine. So this is a large vessel stroke that you get. So this is a large vessel stroke that you get. So then how will you differentiate this from a small vessel stroke? Small vessel stroke. Number one, as far as small vessel stroke is concerned, the one thing that separates a small vessel stroke is a subcortical stroke. You will not get a cortical symptom and sign. Number one. So remember, in AC and MCA, you had a tremendous amount of cortical symptoms and signs. For example, you had disinhibition. Definitely, it's a cortical symptom. Abulia is a cortical symptom. Release reflex is a cortical symptom. Then this kind of difference between arms and legs is a cortical symptom. And aphasia is a cortical symptom, which means in a large vessel stroke, you will have some cortical symptoms and signs to substantiate that is a large vessel stroke. But here you will not have any cortical symptom to substantiate that it's a large vessel stroke. So you can tell it's a small vessel stroke. Number two, as I told you, whenever you get a large vessel stroke, there will be differential distribution of weakness. For example, in AC territory stroke, your legs are involved more than the arms, whereas in MC territory stroke, your arms and face are involved more than the legs. But whereas the small vessel stroke is concerned, there will be no difference usually. I mean, in fact, there might be difference, but there won't be much difference between the arms, legs, and the face, in the sense like there will be equal distribution of weakness in all these areas because it's not cortical. And this is what we refer to as something called a dense hemiparesis. Do you understand? This is how you substantiate that the lesion is in the internal capsule. This is what we really mean by something called as a dense hemiparesis, where there will be no difference to tell that it's a cortical stroke, or there is no difference to tell it is a large vessel stroke. Do you understand? Yes or no? Yes. So now what we need to do is we need to find out what are the arterial territories. What is it is going to do in the first place. Further, we need to understand how the MCA courses in the first place. For that, let me try to show you a diagram if possible. So this will be a good diagram. Yeah, this is a very good diagram basically. So let me try to add it because I want to draw something, but I'm not able to. Yeah, hopefully I can add. So I'm able to add, right? So this is an image of an MCA territory. So, I mean, even though it's showing the ACA predominantly, but we can see the MCA here. So let me draw in a different color. So let me draw in blue. So this is basically the MCA. You can see the MCA courses from the internal carotid artery. So this MCA, this portion that originates from the internal carotid artery is what we basically refer to as something called a M1 segment. M1 segment of the middle cerebral artery. All right. So after this, you have the M2 segment, which I'll show in different color. So this area is what we refer to as a Sylvian segment. And let me draw in the lateral angle so that you'll understand better. So this is the M1 segment. So this pink color which I have drawn here are the Sylvian segment. So this is also referred to as something called a M2 segment. Then we have the final mixed color, which I'm drawing here. So these are the cortical segments of MCA, which means these are the cortical branches. So these are also called as M3 segments of MCA. As far as M3 is concerned, you can see that it courses up and down like this. This is what we refer to as a superior division of MCA, and this is what we refer to as something called the inferior division of the MCA. So which means now you know what you mean by M1 segment. It's a proximal MCA, which gives rise to the M2 segment, which is going to give the Sylvian segment. From the Sylvian segment, you get the M3 segment. That is the two branches, cortical branches. That is the superior division and the inferior division of the MCA. At the same time, you can see some branches that are originating from the M1 segment of the MCA. What are these branches basically? What I am drawing right now. What are these branches which I have drawn now? Yes, these are the branches. These are the famous lenticular-striate branches. So I can draw here. So these are the famous lenticular-striate branches, which means these are the smaller vessels that we are talking about. Okay, you want me to use green color for lenticular-striate. Okay. Okay, let us use green. So these are the lenticular-striate branches. All right. So lenticular-striate branches. So these are originating from the M1 segment only. Suppose, I mean, if they ask you the most important branch that comes from the M1 segment of the middle cerebral artery is the lenticular-striate branches. Then M1 gives rise to M2, that is the Sylvian segment. Then M2 gives rise to two more segments, that is superior division and inferior division, that is the M3 segment of the MCA. Fine. Like that, you have for AC also you have a lot of segments, but that's not really important. Nobody is going to ask because MCA is going to be the most common, most important anyways. Now, having known about these branches, and most importantly, one doubt will be absolutely clear for you because these lenticular-striate branches, you can see they are absolutely subcortical and they are end arteries, which means they are small vessels and they cannot be seen on angiography. Very important. In angiography routine, it could be CT or invasive angiography. You will not be able to see the smaller vessels properly. So of course, you will not be able to look at them. So these are smaller vessels. They are supplying the subcortical areas. Typically, they are supplying the basal ganglia and the internal capsule area. Because you know, internal capsule is going to come in this direction only. I mean, I'll draw that later on. Internal capsule is going to be in this particular zone only. But nevertheless, these lenticular-striate branches are going to supply the basal ganglia and the internal capsule. So usually whenever you have a lenticular-striate occlusion, you will have damage to the internal capsule, which is a subcortical area, which means you will not get any cortical symptoms and signs, and there will be absolutely no aphasia or no cortical symptoms and signs that we'll be looking for. Okay. Now let me draw the lateral surface of the brain now. If you draw the lateral surface, you'll be understanding much better. So this is the brain I'm going to draw so that it'll be easier for you. So if you draw it in hand, it will be more easier. That's why I'm drawing it. So you can also draw it yourself. So this is one of the worst brains that you can see, but still it is a very conceptual brain. So this is to show that this is anterior side, this is posterior side, and this is going to be the brainstem. And brainstem is not important for me right now, but I can tell this is the brainstem to show that it is the posterior area of the brain. And you know what is this particular structure? What is this? What is that structure? Yes, that is basically a Sylvian fissure, or otherwise referred to as a lateral fissure. And that's what you have been seeing here. This area you have seen, no? This particular zone. So that's the Sylvian fissure. Clear? So that's seen in the coronal plane. Now we are seeing in the lateral angle. That's all. The sagittal plane right now. So apart from that, you have multiple areas. You know that. Only important things I'll draw. So one is the central sulcus. So you know this is a central sulcus of Rolando. And you have a pre-central sulcus and a post-central sulcus. Just a conceptual diagram. And of course, you need to know that this is a post-central gyrus. Remember, this is a primary sensory cortex. So you need to be very clear that it's a primary sensory cortex because you have a lot of sensory association areas also. And of course, you know this is a pre-central gyrus. And this presents the frontal lobe and it's a primary motor area. And you have a lot of motor association areas as well. And based on this, I'm going to construct certain other things also. Like for example, I can tell there is one more area here that is present like an angle. So this particular zone that is created near the angular sulcus is what we refer to as something called an angular gyrus. So this area is the angular gyrus that is present basically in the parietal lobe, as I showed you. So you know this is the temporal, this is the frontal, this is the parietal, this is the occipital. We know that. So I don't want to tell that for you. It's a very simple anatomy. So that's the angular gyrus that we're going to look out there. And if you ask where is the Wernicke's, I mean Broca's and Wernicke's area, for that we need to put the two more sulcus. So this is the superior frontal sulcus and inferior frontal gyrus. And they're going to form three important gyrus there. So one is the superior frontal gyrus. Then you have the middle frontal gyrus. Then third, of course, you have the inferior frontal gyrus. And many areas are there, but these are the most important. Inferior frontal gyrus. We know in the inferior frontal gyrus, you have a very important area here that is called as Broca's area. Approximately. This is where Broca's area is located. And of course, in the temporal lobe, especially at the parieto-temporal junction near the posterior side, you have another area. This is going to be the Wernicke's area, basically. Wernicke's area, basically. And you know, Wernicke's area and Broca's area are going to communicate with each other through something called an arcuate fasciculus. So that arcuate fasciculus is going to wind up around the angular gyrus. And this is how arcuate fasciculus will be there. So that's how arcuate fasciculus is all about. And you have other areas. For example, you have an area on the top, like near the precentral gyrus. You have another area called as frontal eye field. So I can draw something like an eye. This is going to be a frontal eye field. I'll tell you what is the importance of frontal eye field in some time. So that will be the frontal eye field. Then of course, near the frontal eye field, again an approximation, there is a vague area. This is not well localized. That's called a premotor cortex. Premotor cortex, it's like an association area to the motor area. So that's a premotor cortex. And of course, in the tiny strip, if you see, this portion is what we refer to as something called a prefrontal cortex. So this is the prefrontal cortex that we're talking about. So which is the seat of social activity and social behavior, right? So I don't want to draw the auditory areas. I don't draw the visual areas. So I can just post that probably somewhere around here, you're going to have the auditory, I mean, the occipital lobe. I really don't want to show, you know, like the exact location, but somewhere around there, you're going to have the occipital lobe. If you take the blood supply, let me draw different colors. For example, this particular area, you know who will be supplying this particular area? Who's supplying this particular area? Yes, this is a PCA territory, of course, even in the lateral hemisphere. And let me draw one more territory. Who's supplying this area? Of course, it is anterocerebral artery. That's an anterocerebral artery territory, of course. And remaining everything, whatever I have left here, will be basically supplied by the middle cerebral artery only. That is why we tell the artery of the lateral sides of the brain is the middle cerebral artery only. So if you take the lateral surface, it's predominantly supplied by the middle cerebral artery. The medial side is predominantly supplied by the anterocerebral artery. The inferior and posterior, if I take the posterior and the inferior sides of the brain, it is PCA. So lateral MCA, medial ACA, inferior and posterior it is PCA. So that's how the supply is going to be. So which means whatever I've drawn here, everything will be supplied by the middle cerebral artery only. So how can you tell the middle cerebral artery supply? FEF by MCA only. Of course, it will be by middle cerebral artery only, not by ACA. So let me show. Whatever I told you here, remaining everything is MCA only. Don't take in the literal sense. Even a lot of accession areas are basically supplied by middle cerebral artery only. So now how the middle cerebral artery is going to course, that's easy to understand, because we know in the previous image we saw that this cortical branches, the sylvian segment is there in the sylvian fissure, that's the lateral fissure, and the cortical segments are emerging out of the sylvian fissure. That is seen in the coronal plane. So of course, when you take in the lateral surface like this, your middle cerebral artery is going to come out of your sylvian fissure, isn't it? So that's the M2 segment that I'm drawing here. From the M2 segment, you're going to get two divisions, that is superior division and inferior division, that is going to go on the top and go on the bottom on the lateral side of the hemisphere. So which means I can write, the divisions I'm not going to tell exact divisions, but anyways, there are two divisions are there. One is going to be the superior division, another is going to be the inferior division. So just understand the concept, that's all. So I'm not drawing the exact anatomy once again, just the conceptual anatomy. So this MCA has a lot of branches. For example, it can supply the Broca's area, separate these things there. It can supply the frontal eye field. It can supply other parts of the frontal cortex. It can supply the parietal lobe. Yes, it can supply the precentral gyrus. It can supply the postcentral gyrus. So superior division is going to supply a lot of areas. So I can draw this separately. So this is the superior division. You can see the supply. So typical superior division supply is going to supply a lot of areas like this. As far as the inferior division is concerned, inferior division predominantly is going to supply Wernicke's area, a lot of auditory cortex also, and many different areas in the temporal lobe. They are going to be supplied by the inferior division only. So I can draw inferior division here. So which will be supplying huge number of areas. The most important area that is going to be supplied by the inferior division is the Wernicke's area. So these are going to be the supply for the supply by the inferior division of the middle cerebral artery. And more importantly, more than the, please mark it as superior division and inferior division. We'll take it a snapshot. Okay, you want to know that. Okay, so this is the superior division and this is the inferior division. I can write here. This is the inferior division. Okay, inferior, and this is going to be the superior. Okay, all right. So apart from that, you have many other areas that are important. For example, you have in the parietal lobe, we have an area called as superior parietal lobule and inferior parietal lobule behind the angular gyrus. Let me call this zone as superior parietal lobule. And let me call this area here somewhere. This is an inferior parietal lobule, which has its own function, which I'll be discussing in some time. Inferior parietal lobule. And you have a lot of other areas also. And at the same time, you have some optic radiation fibers that are passing through the inferior part of the temporal lobe and the superior part of the parietal lobe. For example, which color we can use for optic radiation? I can use this differential color. For example, let me assume that I have some few optic radiation fibers that are traveling to the occipital cortex through the parietal lobe. And you know, there are some optic radiation fibers that are traveling through the temporal lobe to the parietal to the occipital cortex. So what are these fibers called as? We know these are basically Baum's loop fibers. It's very simple. And these fibers are basically called as Mayer's loop fibers. This is what we have been talking about. That is the reason why whenever you have an MC stroke, whether it's a superior division or inferior division, you might result in development of visual field defects because you're affecting a chunk of optic radiation and optic tract also. So probably that is one reason, main reason why majority of the MC strokes will have this kind of visual field effects as well. It's not only the involvement of the PC or the occipital cortex that is going to result in development of visual field effects. It's the MC-territory infacts also. In a large way, they can produce visual field effects because they are going to cause defect of this kind of Mayer's loop and Baum's loop fibers. And apart from that, even internal capsule involvement can result in development of visual field effects, which will be discussed subsequently. And if you take the motor supply, so we know that this precentral gyrus is a motor cortex, primary motor cortex. And if you take each and every area here, so this topmost area is going to supply the feet, and then you're going to get supply from the legs. So this is what we refer to as motor homunculus. Then you will get the trunk supply here. Then you will be getting the arm supply here. Then you'll be getting the hands supply here. Then you'll be getting the face supply here. Then you get the tongue supply here. So what you're noting here is this AC-territory infarct typically is going to affect the feet and the legs predominantly. So feet will never be spared in the setting of, in the setting of an AC-territory infarct, and feet will never be involved in the setting of an MC-territory infarct. That's why I told you, when you get a cortical stroke due to ACA, your legs weakness will always be more than the arm weakness, and feet involvement will be definite. Whenever you get a AC-territory infarct, your arm and face weakness will be more than the leg weakness, and feet will be definitely spared. You will never have feet involvement in a MC-territory infarct if it's a cortical infarct. So if it's a large vessel infarct, if it's a subcortical infarct, then situation can be different. So that is because of the distribution of the motor homunculus, and that's why it is working like that. And similarly, on the exactly other side, for example, turn onto the medial side, on the medial side of the brain, exactly opposite to where you have this feet and the legs, on the inner side, on the medial side of the brain, I cannot show you, just have to flip it and see. You have the paracentral lobule. That is the motor area for the bladder and the bowel. That is for the sphincters especially. So whenever you have a PCA territory damaged, a PCA territory damage is there, especially because it is actually supplied by the anterior cerebral artery, you can result in the development of incontinence. That is very classical of a PCA territory, AC territory infarct, anterior cerebral artery territory infarct. So I think this must be giving you a good idea. So now based on that, I can tell my artery of involvement, isn't it? For example, I can have a superior division involvement. So in the MCA, what will happen if my superior division is involved? What will happen if my inferior division is involved? What will happen if my lenticular side branches are involved? I think Shubham is asking for a break so that you can go for a small break and come. I'll start by 7:15. This diagram is going to be very important. It's a very conceptual diagram so that it will be useful for your exams. Okay, go for a break and come. 7:15, I'll start the class again. Bye-bye.